Well, it's 11 o'clock and it's good morning and welcome to day 2 of the QNI's annual conference. Welcome everybody. It's lovely to see you arriving and putting your details into the chat box saying who you are, where you're from. That's absolutely brilliant. And we have 225 of you already, and we're expecting a number more that will be arriving over the next few minutes while I do the welcome and the housekeeping. So my name is Crystal Oldman, and I have the absolute honour of being the QNI Chief Executive. And I'm also here with our Chair, Professor John Unsworth, and our amazing QNI team. We're all here virtually, not in one place. We're all working in different places, mostly from home. And I'm here with the team who are absolutely incredible, who have planned, developed, organised, and are now delivering this amazing conference. And they've commissioned this fantastic VFairs platform, which I hope you agree looks absolutely superb. It looks like virtual reality. And we've been planning this for many, many months. And I hope that you will enjoy what you see today. Some of you will have been with us yesterday, amazing day focused on evidence-based practice yesterday. But you may not see the team, you won't see the team, they're not on camera. But please do give them a thanks for everything that they've done in delivering this, organising, planning and delivering this conference. And it's all free. So please think about donating to the QNI as we go through today. And if you're with us for the next 2 days as well, please do think about donating to us. We are a charity. We do rely on grants and donations. And I like to think about it as paying forward. If you are able to give us anything as small as a few pounds would be amazing for us. It means that we can come back and do this all again next year. Your donations are really important to us as a charity because it enables us to do the work that we do. Our work includes, as many of you will know, setting standards, supporting nurses in a number of ways by providing CPD opportunities, just like today, and leadership programs. You can hear a bit more about those in one of the round tables. Supporting quality improvement through our innovation program and our innovation projects. Again, you can hear about that in one of the round tables. And leading a range of free networks for sharing, learning, and influencing. And we influence policy development and implementation, and also we deliver research to underpin our policy influencing work. And you're going to hear from Alison Leary, who's the director of our International Community Nursing Observatory at the QNI, in the work that she does in creating the data and the evidence for our policy influencing work. At the QNI, we provide a voice for all nurses working in the community. And that, as you know, could never be more vital than it is today in the context in which we're all working. So please do think about that donation and allow us to continue with the great work that we do. Thank you. So I won't be with you, I'll be with you for the day, but I'm not chairing for the whole day today. I'm just chairing our first session with our fantastic sponsor. And then I'm delighted that I'll be handing over to a QNI fellow, Professor Brian Webster Henderson, who I'll say a bit more about when I introduce him. And he's going to chair the rest of the day after our sponsor session. So to the aims and the purpose of the conference this week. The theme this year is In the Spotlight, Nurses Leading Care in People's Homes and Communities. And it featured yesterday, and we will continue to feature today and Wednesday and Thursday, a huge range of exciting and uplifting speakers. Twitter was alive with the feedback from our sessions yesterday. So do go, if you're on Twitter, do use the hashtag that you can see at the bottom of that screen there. QNI hashtag is QNI 2023. Please do use that for any tweeting, and we can follow you if you use that. Thank you very much. And what we want is for you to go back to your workplace, or if you're there already and dipping in and out, we want you to feel energized and connected to others, and we want you to go back inspired by what you've heard. So today's theme is workforce development. But I have a little bit of housekeeping first, as you might expect. And my colleague is just going to put up the VFairs landing page, the lobby that you will have arrived in. This is the second time we're using VFairs for our online conference, and we really hope that you're going to enjoy this and that you'll explore all the different features that are there in the lobby for you to click onto, which includes the exhibitor booths, which are in the exhibit hall, and the round table facility that you will, if you're with us tomorrow as well, we have round tables today. You can see that on the left, and there'll be round tables tomorrow. You can go in and out of the lobby area and explore those different features and places on the platform. And there's also an information desk right at the centre there where you can click on while we're live if you have any queries at all, and we will answer those live. As attendees, you will be on mute throughout the day and your cameras will be turned off, with exception of those round tables today and tomorrow, where you will be taken off mute and you will be on camera if you wish. There's a chat facility that you can use, many of you using it, telling us who you are and where you're from. And you can use that throughout all of the sessions. And you can use that also. The other feature that you can use is the Q&A right at the bottom. You can see a Q&A feature. And that comes up in the main sessions. And that's where you can pose a question to the speaker or one of the speakers at that will be delivering the sessions throughout the day. So you can submit those questions using that Q&A button on the screen, and that will be seen then by the team who will be posing the questions, or by the chair who can see those questions coming up, but they won't be visible to everybody. If you'd like to set up speaker view, so you'll be able to see the speakers as they present throughout the day, if you go to the top right-hand corner of your screen, you'll see view, and you can select the option of speaker view there. There's also an option which a number of people used yesterday, which is live captions, and that's at the bottom. There's an option there so that you can have live captions which come onto the screen as people speak. Please, as I said, do tweet throughout the day with hashtag QNI 2023. We're going to be recording all of the main webinar sessions today in the auditorium. And we've recorded those, many of those yesterday, and we will continue to record over the next 2 days. And these will be available for at least 1 month after we close the conference on Thursday. So if you're unable to come to some sessions that you really wanted to catch, you'll be able to see those later on when they're uploaded onto this website, onto the VFairs website. And if any colleagues are away and they're sorry that they've missed it, they can still register and see those recordings later. So that's the housekeeping, and onto the programme. And you'll see in the programme that we'll have an introduction before each of the sessions. We don't like to read out webinars, but if you go onto the programme from the lobby, you can go onto the programme, you'll see the speakers' webinars. If we read out biographies, it just takes time away from the speakers, and everything is there for you to see. I'd like to finally say a massive thank you to our sponsors, which include today, Hallam Medical, our gold sponsor, to Teva UK yesterday, and to on Thursday, our National Garden Scheme Chief Executive is coming to join us. So we'd encourage you to visit Hallam's booth today through that exhibit hall. You can click through on the lobby to the exhibit hall, and you can download useful resources and find out more information about all of our sponsors. And again, those will still be available for a whole month after the conference is closed. So a special thank you to today's gold sponsor, Hallam Medical. And I'm about to introduce you, Lisa. I know you're here, and it is an absolute pleasure to welcome you, Lisa, Chief Nurse of Hallam Medical. This is the very first time that Hallam have appointed a chief nurse. And I have to say, Lisa, it's an absolute joy to have met you several months ago and to be working with you. And Hallam, for those of you who don't know, are sponsoring our CNEN, our Chief Nurse Executive Network, and also sponsoring our ICB Chief Nurse Network. So a massive thank you from all of us at the QNI for that. And I'm really looking forward to hearing from you today, Lisa. So I'm going to go put myself on mute, go off camera, and hand over to you. Thank you.
I think Lisa is not here at the moment, Crystal. I think she may have had some difficulties.
That's okay, no problem. Do we know Lisa was here, wasn't she?
She was, yes.
Yeah, so is she being sent another link to jump in again?
Yes.
Okay, fantastic. So what I'm going to do is, while we're just waiting for Lisa, and Adine, if you just alert me when she's in, what I'm going to do is just ask for Lisa is here but having issues joining. Okay, that's from Ursula from Hallam. Thank you, Ursula. I'm just going to ask if anyone has anything that they want to put in the Q&A. For myself, Professor John Unsworth, our chair, who's here, wants to know anything more about the QNI, so that we don't have any we don't want any wasted time or empty time here, and we're really happy to take questions. Anybody got any questions at all? I know you can't come off mute, you've got to have time to put them into the chat box or into the Q&A. Any one of my team want to come off mute? And
what are your aspirations for the future of district nursing? Louise, for that question. Yeah.
Our aspirations. Well, our aspirations for the future are, we know that in England, the numbers of district nurses have dropped below 4,000 for the first time in 10 years. So our aspirations are, given the focus on more care in the community, given the complexity of care now in the community, our aspirations are to support the growth in the district nursing service, and to support the growth of those nurses who hold the specialist practice qualification. And my colleague here is here with us, Agnes Fanning. Dr. Agnes Fanning has been leading on the standards for district nursing, the QNI standards, which are built around the 4 pillars of advanced practice. And in going back to the questions about our aspiration, it's growth, and it's also about recognition of the district nurse, that team leader with the SPQ, as working at an advanced level of practice and the equivalence of an ACP. Have I answered that one?
Yeah, thanks, Crystal. I do think it's wider than just district nursing, so we're looking at all community practitioners. So Agnes has been involved in leading our work across 9 different aspects of community practice, including some new and emerging roles around custody healthcare, both within police custody but also within prisons. And we really do need to push the agenda around advanced practice. So it'll be really interesting to hear from Sam this afternoon about the NMC's review about whether to regulate advanced practice. So yeah, we are pushing both the numbers, and we've had quite considerable success with policymakers through our shadowing programme, where we get senior figures to go out for a day with a variety of practitioners. So people have been out with community mental health nurses as well as district nurses, and yes, Lynn, you're right, also health visiting and school nursing is a focus, and we obviously work very closely with the Institute of Health Visiting and SAFNA, the School and Public Health Nurses Association, around that. And the Institute of Health Visiting have been instrumental in trying to secure a commitment to increase the number of health visitors and around school nursing as well. There's another question about how to become a Queen's nurse. So could you briefly outline the process of how to become a Queen's nurse? So applications are currently closed. We've had the 2023 round for Queen's nurses. We open a window and people apply for a what's called a URN, a unique reference number. And that gives us some indication of the number of applications that people are working on. And they complete a written application, and depending on their practice background, so obviously some people practiced in higher education, etc., then people have to get almost testimonials, and so feedback from patients, from colleagues, etc., and from their line manager, as well as to complete an application form. Once that's submitted, then it goes out to reviewers and gets moderated and externally assessed. And then we welcome a new cohort of Queen's nurses around November, December time. And I can see Lisa's here, so I'm going to shut up. Hi, Lisa.
Good morning. I apologise, everyone. Technology worked perfectly yesterday when I was a participant and let me down today as a presenter, so I apologise. So, Crystal, thank you very much for the introduction. As Crystal said, my name is Lisa Locker and I'm Chief Nurse at Hallam Medical. Firstly, can I say how excited I am to be invited by the QNI to talk to everyone and such a large group of dedicated professionals about the work we do at Hallam Medical and a little bit about my role as Chief Nurse. So next slide, please. So we're going to do an overview of Hallam Medical, talk a little bit about our vision and values, share a little bit of our case studies from our clients and our clinicians, talk a bit about our partner working, and then just going to talk to you about the role that the Chief Nurse and the impact it's had at Hallam Medical, and then take any questions that I could help you with. Next slide, please, Adina. So we at Hallam Medical are the UK's leading advanced practice healthcare recruitment partner and are the first choice for primary care providers for clinical workforce solutions. We are a framework accredited healthcare recruitment company, and we're based in Sheffield, South Yorkshire, supporting both the NHS and private healthcare services across the UK with the provision of highly skilled community specialists, advanced practitioners and 111 clinical advisors. Hallam Medical was founded in 2007 by our clinical director, Alex Munro, who is an advanced practitioner himself. Our Chief Executive Officer, Deborah McCain, who also holds a clinical background in nursing, joined Hallam Medical in 2013. And Deborah's got a proven track record in the development of strong and transparent relationships that have enabled Hallam to become a trusted partner throughout the UK, delivering individual solutions across all service providers. What are we passionate about? We're passionate about providing quality healthcare professionals to primary care, community, urgent care and 111 pathways across the country. As I said, our senior team comprises of individuals with advanced practice and clinical backgrounds, and therefore we drive that commitment to deliver against the healthcare's market's needs, providing the right staffing solutions to complement and enhance the permanent workforce that's out there, as well as meeting ever-changing locum needs. Next slide, please, Adina. Our vision, our purpose and our passion is about delivering quality healthcare professionals, so that what you ask us for is exactly what we will deliver. Our niche is delivering innovative workforce solutions to specialist healthcare services and thinking outside of the box at time and moving with the times. Recently, so doing some great work on a digital healthcare platform with one of our clients. Our three uniques are our partnerships, our clinical expertise, and our ability to deliver. Next slide, please, Adina. So our values at Hallam are at the core of everything we do. They really are. So we're resourceful. So as I said, we take different approaches to be able to deliver to our clients. We deliver very specialist healthcare solutions, a team. We know amazing things happen when we all work together. And I think that's been one of the most noticeable facts since I started Hallam, that the team are absolutely driven and work together to make sure we achieve. We care deeply about what we do. not just the senior team as clinicians, but everybody who works for Hallam cares about what we're going to deliver and remembers that there's patients at the end of what we are doing. We're very committed to your success. And if you're successful, we'll be successful. We're trusted. We hold the highest standards of integrity. And I'd like to just give a bit of personal insight here. Before I came to Hallam, obviously lots of years in the NHS, working with different temporary locum providers, I never felt that they were telling me the truth. There was lots of promises to deliver, but not always what you asked for was delivered, making it extremely pressured for the permanent staff that were there. That is not what we do. Since I've arrived, I've noticed the honest and trustworthy relationships that Hallam have with their clients, and that if they can't deliver, they say they can't deliver. What a positive environment it is. There's such a positive approach amongst the team and good relationships with clients and candidates to make sure that we can overcome most challenges. And I think this has a personal thing for me, because as a very, very junior staff nurse, I always remember going to a matron and saying, we've got a problem. And what she used to always say to me is, we don't have a problem, Lisa, we have a challenge to overcome. So that resonates really well with me. Next slide, please, Adina. So you might say that is what the chief nurse of Hallam would say, but as the old saying goes, the proof is in the pudding. So I'd just like to take a minute for you to just look at what some of our clients say about us and the work we do with them. And if we could go on, Adina, to the next slide, our clinicians are just as important to us. So we work really closely with our clinicians to look after them and make sure that they feel cared for. And that's just a few of the comments that our clinicians make about us. So if we could go to the next slide, Adina. So I don't think I need to labour some of these points. These are our partners, and we're very proud to be partners with the QNI, the CNAN and the ICB. We're also partners with API. And I'm sure most of you will have heard of that, but if you haven't, it's a network of higher education institutions across the UK that provide advanced clinical programmes of practice for interprofessional groups. And this is a great partnership as well. It gives us a far-reaching audience. It allows us to horizon scan, know what's coming in advance in practice in the future, so we can be proactive rather than reactive. Next slide, please, Adina. So a little bit about me. I don't want to bore you too much about me, but I hold over 30 years experience within a number of NHS settings as an advanced nurse practitioner and as a senior clinical manager. And I've also had international experience in Trinidad, working with a charity where we used to go over for a month at a time and provide cardiac surgery for patients because they had no cardiac surgeon actually in Trinidad. I ensure I'm still a practicing advanced nurse practitioner, working at least 1 shift a month, ensuring that my knowledge and skills are up to date so I can support the clients, the candidates, clinicians, anything I need to do. Be responsible for clinical governance and safeguarding and work closely with Hallam's clients and clinicians. And that very much fits in the role as a chief nurse and is all what you'd expect some of my major responsibilities to be. Proud to work in partnership and network with our trusted partners. And I will have met quite a lot of you when we've been at the QNI meetings and the CNAN and the ICB. I work closely with our clients and clinicians to enable clinical services to deliver excellent care within primary community, urgent care 111. Next slide, please, Adina. So how do I do that? So at the start of my journey with Hallam, I asked myself that question a lot because being a chief nurse in this role was very new to us all. But how I view it is I bring strong professional leadership. So every day is no different to every day in my career as a nursing, whether I'm in uniform or out of uniform. I not only represent Hallam medical, I represent nursing every day. Significant clinical expertise and knowledge. So having lots of experience as an advanced nurse practitioner and other senior roles dealing with governance and complaint safeguarding, I try to use that to ensure that everything we do every day is the best that we can do, and our clinicians are well supported by us. Clinical governance and safeguarding. I previously held a role within Sheffield Teaching Hospitals as Deputy Nurse Director, where I was responsible for the care group's clinical governance and safeguarding. So significant amount of experience in those areas. Promote education and lifelong learning. So this is something that I am very passionate about in this job. I think being a locum worker, it can be very hard to tap into education and, you know, get support and carry on learning. So how do I do that? I do that by regular blogs, our website, working with our clinicians, working with clients when there are issues with knowledge gaps, and ensuring that we address those and support our clinicians to be the best that they can be. I promote, support and get involved with research as well to encourage best practice. Again, try and do this through blogs, pointing people in the right direction. I found the sessions yesterday on research extremely interesting and gave me a lot of new ideas of how we can get our clinicians involved in that. And most of all, as I said, I do what I've done every day as a nurse. I'm dedicated to deliver excellent clinical outcomes for every patient that we come across. Work closely with our partners to be ahead of changes and develop our solutions and workforce accordingly. And this is what I said about the partnerships and the horizon scanning. Advancing practice is going to continue to move at a very fast pace, and to be at the forefront of that is not only very exciting, but ensures we can be there to provide exactly what's needed to the patients. Thank you, Adina. Next slide, thank you. Right, any questions? Sorry, it was just a bit of a whistle-stop tour, but as it's such a new role, I thought it was lovely to share it with you and just talk a bit about the work that I'm doing.
That's brilliant. Thank you so much, Lisa. And I believe we do have some questions. So I'm actually going to go to my team. Oh, and it's just come up on my screen. Do you provide, does Helen provide prescribers within substance misuse services?
Yes, yes.
So that, can you give an example, maybe give an example of if you know about it? Because I know your role is so new.
So our CEO is here with me, just in case, because my role is so new.
Hello, Deb.
Hi there. Yes, I mean we've got a number of services across the UK and history of providing into substance misuse and across mental health. We don't have a huge database, but it's certainly something that we would look at individual requirements, and then we'd be able to go out to market and see what would be available.
And if the person that has left that question would like to know more, what would they do if they wanted to contact you directly?
They just drop me a line or Lisa a line if our contact details are going to be circulated, and I'll get back in touch directly.
And we can put those, sorry.
You can also go in the booth as well, and it's got contact details where they can contact us in our booth, come directly to us.
Brilliant. That's great. Thank you very much. Yes, we did talk about that, didn't we, right at the beginning, about going to the exhibit hall. Next question. How do you fulfill supervision in practice requirements? So supervision in practice requirements for the advanced practitioners.
So I do a number of shifts out there clinically with the practitioners. We do reflection sessions with the practitioners. And we are, myself and Alex Monroe, our clinical director, are very accessible to all our clinicians to ensure that they do get the amount of support and supervision they need.
And
that's great.
You were out on a shift at one of the local urgent care centres.
Last Monday, I worked a late shift with one of our clinicians at the urgent care centre, and I'm very passionate about that, about getting out there with our clinicians and working alongside them to understand some of the challenges they're facing as well.
Yeah, Yeah, that's great. Thank you. Next question I've got is management work for staff. Do you provide part-time management work? So are there any management roles that you're pointing to?
Yeah, there are. In fact, we've just appointed an interim clinical lead down in Kent for urgent care services, but we are often looking at more senior roles and leadership roles, and often those do actually convert into permanent appointments should everybody be happy and want to move forward in that way. But we mainly deal with interim posts.
Yeah. Interesting. And what's the conversion rate for, do you know, from those interim into permanent?
At a senior level, it's actually very strong. I couldn't put a number on it off the top of my head, but it is a very strong conversion. Not so strong at a band sort of 8 level and below, because those individuals would generally be making a life choice around doing temporary work as opposed to a permanent role.
Yeah, absolutely. Yeah, no, that's very interesting. Thank you. Your next question that's come through, if staff don't fulfill the demands of the work that they're allocated to, how do you support them? So that's if it doesn't work out.
So I can give some examples of the work I've been doing recently with some of our 111 care providers. So they are, as some people will know, regularly audited and fed back to. I have a weekly meeting with that client, and we go through audits and any supports needed, and then I take that off and I work with that individual clinician to provide that support, reflection, whether it be signposting, good educational resources. So I very much do that on a one-to-one basis with our clinicians, and we've had great success with that, actually.
Yeah, do you want to give an example? And obviously anonymous example.
Yes, so one of our clients, we were struggling with workload and productivity, and actually when I did a lot of work with a clinician, there was lots of reasons for that. There was some knowledge gaps which we addressed. There was technical issues which had not been escalated, and there was just having somebody to talk to and reflect upon some of those calls that had been taken and how hard it is to be in isolation sometimes. So they're examples of the kind of work that I've been doing with our clinicians.
And that's resulted in them staying in the temporary position, rather than, because very often you find with the temporary workers, when something goes wrong, it's very easy for us just to take them out of that role. And as an agency, that's actually really quite a challenge to be able to give that level of support. And that's why we've wanted to extend our internal clinical team and bring in Lisa as a chief nurse to actually make sure that those clinicians get that support and development that they deserve to have in a temporary workforce, because after all, we all rely partially, if not significantly, in the temporary workforce, and we need to make sure that we're able to improve everybody's experiences and our patient outcomes by upskilling and supporting those clinicians.
That's brilliant. It's really good to hear about that clinical support, and then the result being they stay, and develop, which is great. Lovely.
Absolutely.
I have another question. Mental health in primary care as an advanced nurse practitioner is quite a new role. How do you see this kind of provision at Hallam, and how have you already got experience of that? And if you haven't, how are you thinking you might manage that?
Yeah, so we've got some experience of some of the pilots that have been put in place, where we've actually we've resourced and recruited against those pilots, and those services have then gone forward into a permanent role. So like everybody with anything new, still, we'll be exploring. But the answer to it is if we have a service provider that needs our support in a specific role, then we will obviously maneuver to resource against the specific requirements.
Yeah. Is there do you see a trend in mental health that you've got more mental health practitioners, nurses, AMPs who are coming are with you as temporary staff being
We're
primary care?
Yeah, we're definitely seeing the demand. I wouldn't say that the recruitment of those individuals in the temporary workforce is following line, but that will just take a period of time for that to come through. But the demand is definitely there.
And another question, where are you seeing the greatest demand for services for staff?
I would say the community services is definitely the most challenging of all, I think, that we specialise in. The number of community skills and clinicians that are actually available is such a significant challenge to resource for. And I think, you know, we all wish we had that drawer full of just add water community nurses. There's just not enough to cover the demand, and obviously we're having to look at alternative solutions and different skill sets to try and support the teams, but it's very challenging. And I think, you know, the biggest challenge that we hear back from our community nurses is their ability to cope with the workload.
Yeah, it's very, very similar to what we hear. And one of the questions that we had before we were able to reconnect with yourselves, Lisa, was about what's the aspiration for the QNI, the aspiration for the future of district nursing. So when we're talking about community nursing services, is it in all areas? Is it in community children's? Is it in district nursing services?
It's in all areas. It's across everything.
What do you think is the solution?
Honestly, I don't know what the answer is. I think that community specialists are, I don't know what the answer is. I think there needs to be better incentives to get people to either stay or come back. I think, you know, as far as sort of national frameworks are concerned, the community services are put in as a generalist sort of, you know, and that doesn't work for our community specialists, where they're autonomous practitioners and they're not being necessarily recognised as so. So as a temporary workforce provider, sometimes our hands are very tied with what we can and can't do. But yeah, I think there's a lot that needs to be done. I think managing support and workload, and you know, you will all know because you're suffering the same issues and challenges.
Yeah,
Crystal, I think another issue is something that you and I discussed when we first met about district nursing, community nursing, whichever bit of it you're talking about, was always seen as something you couldn't do when you were newly qualified or younger. It was always about being in the hospitals. That's where it's at. And as I said to you, I think there needs to be a lot more publicity, and you guys do a fantastic job of just what amazing jobs there are out there in the community, and it to be seen as the career of choice.
Yeah, there is that rebalancing needed, isn't it? You'll always hear me say it's not a competition about hospital-based nurses and community-based nurses, because we're all serving the same populations.
Absolutely. And people use, as I said to you, I hate that word acute, because everybody only thinks that acute goes off in the hospital. Acute care goes off in every bit of nursing.
Exactly.
Yes. Fantastic. I think that's the most fantastic thing I've just heard this morning. Thank you very much for that. A couple more questions before we finish. A question about where you operate. There's one of our delegates is in Manchester. Do you operate in Manchester?
We do, yes. Right across the country.
Fantastic. There's a request also to put your, I know we've said to go to the exhibitor booths, but if Lisa, when we finished, perhaps you or your colleague Ursula can perhaps put your details into the chat box, so people can, I'm sorry, your inbox is going to be filled up any minute now. Sorry about that. Nice problem to have. And then it says, I think there's one more question about Learning disability. Do you have any learning disability requests for advanced nurse practitioners?
Very few and far between.
Okay.
Is the absolute honesty on that one. And in fact, I would have to go out to database to see whether we had anybody that specialised in that on our database. I'm sure we must do, but yeah, very few.
Yeah. And the similar question, I guess, for community children's.
Yes, so again, we do have them. We have requests for them, but they're not an easy to recruit to.
Yeah. Well, there's probably lots of those who are listening right now. Got lots of community children's, lots of community mental health, lots of community learning disability, and many other fields of practice that will be listening to this today. So, and the very last question before we finish is about social care. Do you place temporary workforce into social care?
Unless it is an advanced practitioner or a district nurse or community nurse that was required in those settings, then it's not an area that we specialise in, no. But
you do place workforce into care homes and nursing homes?
Yes, we do. Yes.
Yeah. No, that's really helpful, because again, we've got some really we've got great engagement with around 2,000, I think it is, care home nurses who are on our care home nurse network, and so that's really good to hear, because as you know, workforce is a challenge everywhere, and is a real challenge, of course, in residential care and in care homes with nursing in nursing homes. So it's really good to hear that. And these are all, you know, again, Lisa, going back to when we first met, we talked about that this is in the community, in all settings. These are nurse-led services, aren't they, requiring that advanced level of skill? So
absolutely. They are very autonomous practitioners that are highly trained, delivering excellent care.
That's fantastic. I think that's the best line to finish on. Thank you so much.
Thank you very much for having me.
Could I direct you to look at the chat box, because you've got some great feedback in there. You've got lots more questions than I could ever. The team have been pulling them out and giving them to me. Lots more questions than I could ever have answered in the time that we've got. But thank you so much for your time today, and thank you so much for your ongoing support of the QNI through the networks that you support with us, for the ICB Chief Nurse Network and for the Community Nurse Exec Network. We are truly grateful to you, and you've been doing that for a number of years. This is probably year 5, I think, 5 or 6, which is incredible as a supporter. Thank you so much, Deb and Lisa and team who are behind you there somewhere as well. I know.
Absolutely, our privilege, Crystal. Thank you.
Thank you very much.
Brilliant. That was a great session, great way to, I'm all energized now, and really great presentation. And I'm going to hand over to Brian. Brian is going to be chairing the rest of the day. Brian, I think you've just come out of a big meeting at your university, so I'm truly grateful for you to extracting yourself. I hope that wasn't too difficult and didn't leave you in a difficult position to say goodbye to your colleagues and come onto this call.
Not at all, Crystal. I'm so delighted to be here. I'm struggling with my camera a little bit, so forgive me, folks. Really delighted to be here, and it's great to be invited back and to chair this session. I've not long come back from a holiday in Cyprus, but came back with COVID, so I've been off last week, absolutely wiped out, but was determined to absolutely get here so I could join in the day's events and activities. And it's a really important time for us as health professionals to come together and really have that spotlight focus within this conference on those that work in the community and in people's homes. So I'm delighted to be here. So enough from me, let's move on. While I was in bed last week, I was thinking about Alison. Now that might sound an odd thing to say, but the reason I was thinking about that was I thought that question I asked myself is, what is it that I really admired about Alison? And the first thing that came into my head was, well, I like the fact she's outspoken. But over the weekend, I really reflected on that and I thought, no, it's not outspoken. It's been able to have an eye and a line of sight to say the really important things that matter about our profession, and being able to have the courage of one's convictions to stand up, speak out, and really call things out. And they're great qualities. So Alison, our profession is all the more better for having you with us. So I'm delighted to welcome Professor Alison Leary, who is also not just a professor at the London South Bank University, but is also the director of the International Community Nursing Observatory, which was launched by the QNI in 2019. Alison, great title for your presentation, the Community Nursing Workforce, Where Are We Now? I'm going to hand over to you. Thank you.
Thank you so much. And yeah, I'm not sure how to follow that. I think one of the nicest compliments that someone ever gave me, it was Gail Adams actually of Unison. She said, I'm not afraid to be unpopular. And that's very true. I'm not afraid to be unpopular, but to be honest, sometimes I think if you present data, it's not always the most popular thing to do. But I'm going to talk today a little bit. I just need to sort out the screen sharing because I think we're in a bit of a conundrum here. So hopefully you can see this.
That's good, Alison.
Yeah, we're good. Great. I can see I'm glowing in pink, which means I must have the pink QNI slides up. So I'm going to talk about where we are now. So the ICNO has been pretty busy. Dave and I, so Dave Bush and I, have been doing quite a lot of analysis, and we've been working with lots of other people. I'm going to talk a little bit about that, but I really want to talk about where the community nursing workforce is right now, because we have some substantial issues, as you know. We do have almost 50,000, so in England alone we have 50,000 RN vacancies. I think it's around 5,000 or 6,000 in Scotland, and it's fairly similar. I think there have been some fairly significant issues in Wales recently. DNSPQs in England have dropped to under 4,000 for the first time since records have begun. That's employed people in the NHS. So that's quite a significant drop, and I'm going to talk a little bit about that. We have a financial model currently in healthcare across all 4 countries, which promotes workforce skill dilution and substitution. We've seen this in the public sector for quite a long time, for about 15 years. Healthcare has been slightly protected from it, but at the moment, what we're seeing now is much more overt frontline skills dilution. And they're wedding to the Christmas tree. So when we think about the Christmas tree model, it's a workforce model that's used in areas like retail grocery, where you have some very highly skilled people, and then you have lots more sort of perhaps inexperienced and less qualified people filling the Christmas tree. Sorry, I've got some issues with my hard drive at the minute. We've got pandemic pressures, everybody's exhausted, we're seeing a lot more burnout, we're seeing a lot more people leaving because of, for the first time, when we look at the overall workforce data in the NHS, retirement used to be the biggest cause for leaving. That's been overtaken now by work-life balance as a reason people say they are leaving. Leavers data is a little bit difficult to handle in particularly in the NHS in England, because what quite often happens is the categories for leaving are fairly positive. That you can't say I've been bullied and harassed out of my job in that workforce data. So we've actually been looking at people's reasons for leaving, and that goes across all 4 countries. So leavers data is a little bit, it needs digging down into, really, to understand why people are leaving. And people like the NMC actually do quite good work in this area. They look at more detail about why people, for example, leave the register. We've still got a lot of job titles, even in community nursing, huge amount of job titles. We're currently analysing those. I've got 77,000 job titles in my database. And we find the ubiquitous, what we call the ubiquitous practitioner, is really, really solid in that data set. So people called practitioner who range from people with master's degrees to people with no qualifications whatsoever, or jobs, I should say. So it's a really tricky one, because we've got, you know, just talking about, you know, what kinds of roles and identities, and it's really difficult without a brand, as it were. We're still seeing industrial action continuing. So even though the RCN have in England, so in Scotland, they've settled. I'm not entirely sure the situation is in Wales. In England, although they didn't get enough votes to strike, they are still in dispute. The RCN are still in dispute with the government over pay. But we have seen agreed now the money for the GPN or the GP staff uplift of 6% in pay. So hopefully, if you're working in general practice, you're going to go and claim that from your practice. We still see a lack of development and succession planning, and we constantly deal with the fact that nursing is what we call a pink collar workforce. Even if you're a man in it, you'll be paid less than people that do work of equivalent complexity and equivalent in terms of safety critical work. So, you know, there is an issue there. We also see this lack of engagement in workforce policy across nursing, where big decisions are made where no nurses are at the table. And as Crystal always says, be at the table or be on the menu. So, you know, that's one of the things I think we perhaps need a more coordinated input into, actually. So let me see if I can move my slides on. So where are we now? So the RCN has just issued its updated definitions of nursing. You will see in those nursing defined for the first time in its 106-year history with the RCN as a safety critical profession. Yeah. I don't know why it never was in the past, but it is, and it is the area of risk that nurses manage that's always been unrecognised, and I think therefore help with its devaluing, whether that's in hospital, in homes, in care homes, particularly in care homes, I suspect, at least looking at coroners, prevention of future death notices. These are areas that are really, really big areas, and I'm very glad to see that it's there. The second part of that piece of work, the piece of work that will follow on from that, is the definitions of enhanced, advanced and consultant level nursing practice. I'm very, very pleased that they've done this. There needs to be clarity around it, and it needs to cover all 4 countries, because currently everybody's doing something different. The other professional groups have already done this, so the radiographers, the physiotherapists, the OTs, they've already defined this themselves. And I think that really fits in really nicely with the work that the NMC are doing at looking at advanced practice and recognising advanced nursing practice, as opposed to where we've shifted in terms of advanced practice, which is towards the medical model, and that being recognised as advanced practice. And that's meant that some workforces that do practice an advanced nursing practice level, for example, district nurses, specialist nurses in the community that are managing big caseloads, have been devalued. So I think this will hopefully pull back from some of that. We've got an NHS workforce plan in England, 150 pages long. Focuses a lot on supply, not a lot on retention. We'd like to see more retention in that. But there is quite a bit on district nursing in it, which is actually really good. And I suspect, thanks to Crystal. But we're seeing these strategies also emerging from the other UK countries. So important that if there is a consultation, it's really hard, I think, for individuals to then go out and say, well, you know, I'm going to read this massive consultation document. But if you belong to a professional association, make sure you have your say when they're asking for these things, because that's how your voice can be heard. We've seen lots of policy initiative, particularly in post-pandemic recovery, that don't include nursing. So the GP recovery plan in England. The other countries seem a bit more inclusive. And Northern Ireland, there seems to have been a bit of a hiatus, I think, because of what the political situation is there. So it's a little bit difficult for Northern Ireland. There still seems to be quite a lot of good work going on. But again, it's really about using a collective voice to have a policy. So the big ones that I've seen: GP recovery plan, emergency recovery plan, no nursing at all in those. The winter pressures planning, no nursing input at all. And surprisingly, in England, there's been a policy about new uniforms, which didn't have any nursing input, which I was a bit mind-boggling because they're the biggest workforce. But there you go. So, well, hopefully now the RCN are pushing away at that one. So I get a lot of messages about the new community safer nursing care tool, which is being rolled out in England. I haven't seen it. I don't know what powers it. I don't know what modelling was done for it. It would be really good if you're going to use it, or you're thinking about using it, or you are using it already, to get some feedback on that so that we can maybe share that feedback. No tool is perfect. Most tools, so the hospital version of SNCT underestimates the demand for labour. And particularly in areas like organisational labour, so Davina Allen's work in Cardiff, and emotional labour. So what we always end up with is a deficit in labour. So, you know, you end up with more work you have to do to deliver your service than these tools allow for. And this one might be a lot closer to labour demand, we don't know. So it'd be really good to get some feedback so that we could share it. And also most of these tools have some sort of area where they perhaps don't work so well. And until you try them in big populations, it's really hard to say. So if you've got any feedback, it'd be great to hear from you, and we can maybe share that so that other people can learn from it. And then we've got, these are two things that might have passed you by, but they're actually really big things. So we've got the Professional Records Standards body that are developing standards for how nursing is recorded. So those big EHR systems, the things I'm constantly asking you about. PRSB standards didn't seem to include anything, although there was a nursing piece of work done, they didn't actually consider the nursing process, and they didn't consider any kind of models of nursing that you might be using. They said it was really about recording tasks. So we've kind of challenged them on that, actually, and we've asked the RCN to go and re-look at that. The reform of nursing documentation, which some people at NHS England are leading on, seems a lot better. So that's really about using the technology, and a lot of the issues you come to us with about the poor use of technology in a much more thoughtful way, so that you're not constantly putting in the same data, for example. So there's some good stuff going on, and there's some stuff I think we need to keep on our horizon to make sure that they don't destabilize the nursing workforce. So we've also seen, so in the NHS England workforce plan, we've seen mass expansion of essentially the return of non-graduate nursing, the nursing associate role. I think the NHS England workforce plan is looking at around 63,000 nursing associates over the next few years. And we know nursing associates are being used as substitutes for RNs. So, I think many of us heard the narrative when nursing associates were introduced that they would be supportive, that it would be bridging the gap between RNs and healthcare assistants, even though there was no gap articulated. The shortage has always been in RNs. So, and I think a lot of us knew that this was really the return of second level nursing. It appears now that, this is actually a quote from a civil servant, that actually it is around the return of non-graduate nursing. Some people might welcome that, other people might not welcome that. As a modeller in safety critical industries, it kind of worries me for a number of reasons, but it's something I guess is here. So we need to think about how that's going to work out in the real world. But this is now policy. So we kind of need to think about that a little bit. So some of the things we're working on that I thought you might be interested in. The workforce standards have been out for about 18 months now, and we're getting some really good feedback on where they're useful and maybe where they need improving. We'd really like to hear from you about what works with them and what doesn't work with them. And you know, these were for district nursing. The impact of technology, so nursing in the digital age, I'm going to talk a little bit about that. It was a big cross-sectional survey we did. We've worked with the Parliamentary Healthcare Select Committee on workforce with this, because what you told us, I'm going to kind of show some of the results, but it showed us that technology was not enabling your work. It was actually proving to be a challenge in your work. So we've kind of fed that back around that, and there's going to be some more investment now in technology that hopefully is going to be a bit more sensitive to your needs, and I'll talk a little bit about that. During the pandemic, we did some work with care homes, and we looked at some of the experiences of people working in care homes at the time. And as you know, we uncovered this issue of blanket DNA CPR notices that were being issued. They are illegal in England. Well, they're illegal in all 4 countries. So after Amnesty International took up that work, we've also submitted that to the COVID-19 inquiry. So this is just really to show you where your data goes. When you fill in our questionnaires and you fill in our surveys, and you're really, really great at doing it. But I wanted you to know that it just doesn't end up in a file somewhere. It actually ends up going to places that will hopefully influence the lives of our workers, but also the lives of the people that we serve. And I think that's really important. So a couple of things I'm going to talk about today, which might be interesting. So we looked at where all the district nurses have gone. So in the NMC data, there are 14,000 people with DNSPQ, but there are not 14,000 people working with DNSPQ in the NHS. So we want to know where they've gone. I'm going to talk a little bit about something that we've just got some preliminary results on. So we've got the additional roles and responsibilities scheme in England, which introduces different types of workers into general practice. But typically with NHS employment practice, there's been no workforce impact assessment. So what we would do normally in many industries, if you're going to make a major change, is you would do a workforce impact assessment. Doesn't matter if it's technology, introducing new jobs, introducing new processes. You would do something called a workforce impact assessment. And that has never really been done in healthcare. People just don't do it. So we've done a retrospective one with general practice nursing. And I'm going to show also a few little tasters of our really, really big survey that we do, which is District Nursing Today, which was last done in 2019. Because we're gonna compare what it was like then to what it's like now. So, and that's the District Nursing Team Leaders Survey. So where have all the district nurses gone? So when we look at, so this is NHS England's data of people employed as district nurses. The bottom blue line is people with a DNSPQ. So as you can see, there's been a fairly significant drop. But if you ask anybody from particularly government, they'll say, we've got more nurses than ever before working in the NHS. And that's true, we do. But as you can see, the people without DNSPQ, so the top blue line is RNs without DNSPQ, which has grown. And also the pink line in the middle is support workers, which have grown. That's also been inflated by nursing associates. Interestingly, someone in the last session asked a question about community matrons. They have dropped like that. So I can pull all this data apart. I've amalgamated here just so it's easier to see. So community matrons have dropped enormously. So if people are looking for promotion as a community matron, those jobs seem to be disappearing, to be honest. So that's the situation in England. And then if you look at Scotland, so Scotland don't, in their data, in their national data, their publicly available data, record DNSPQ. But what we can see in Scotland is a downdrift in pay. And we've been tracking this downdrift in pay for quite some time. I've been tracking it with the clinical nurse specialist community, but what we're seeing is more lower paid people. So 50% of their workforce are band 5 now, which would be quite unusual if you consider district nursing to be an advanced practice role. And you see actually less than 10%, 8% of their workforce are band 7, which is where I would put the minimum for an advanced practice role. So there's a story there that I think needs to be unpicked. And you see this in the other community services. So school nursing is just generally in decline. Now, this could be because school nurses are not employed in the NHS very much now. So it could be that there are still school nurses, but they are not being employed by NHS employers. So the blue line there, the one in the middle, is people who are qualified, SCIFN people. And the purple one is other registered nurses. Community mental health also shows that pattern that district nurses are showing. So what we're seeing in community mental health is that support workers are actually I expect support workers to go up, actually. But you can see people with the community mental, the specialist practice qualifications, or people that are adult, community health branch trained, are going down, and other first level nurse is going up. So what we're seeing is the rise of what we would call omniprofessionalism, people being interchanged for others without specialist qualifications. So that's something I think we obviously need to look at maybe a bit further. So this is district nursing, same graph as before, just the axis has changed. Shows you this quite big dip that's going down. So less than 4,000 in July, and it's well less than 4,000 now, actually. Dropped from 7,000 about 14 years ago. That's people with DNSPQ. So where have they gone? Well, some of the time, so what we have from the NMC is the records of 750,000 people. And then we pulled out the DNSPQ people, which is about 14,000. And about half of them say where they're employed at their last revalidation. So that's what we've used. And then we coded each of those employers into different categories. So this is a very, very, so anyone that's less than 1% we haven't included, but it reads clockwise. So so the first one is, so 1% of people with DNSPQ now work in aesthetics. They're now doing your Botox. So, who says nurses are not entrepreneurial, right? And then what we see is we come right round. So 12% working in social care now. 12% working in acute NHS. So sorry, I've used the word acute. Working on wards or intensive care in hospitals, or maybe outpatients, but a specific hospital-based job. Then 16% working in general practice. So district nursing seems to be a supply route into general practice. And then we've got others. So others are all sorts of places like legal. So people that were less than 1% of the workforce, legal services, PIP assessors, all sorts of people like that. And then we've got quite a big chunk where we don't know. So that they've given an employer that is an acute and community-based NHS employer. So that means it's a little bit difficult for us to say if they're working in a district nursing service or they're working in a hospital setting, because they're people that employ both. There's some really interesting ones. So industry is quite popular. So that includes occupational health. So you've got district nurses working in occupational health there. So it just shows you actually how talented and flexible this work pool is. So, it's a very, very agile workforce. And in terms of talent management, if we were working in industry, we'd be going, oh, these people are fantastic. They're real multi-skilled people. And I get a lot of messages from people that I'm an X sort of nurse, I can't do anything else. That's just not true. Okay. And I always think it's better people stay in nursing and maybe move jobs or career pathways than completely leave the profession. So, change is as good as a rest, right? So there you go. So nursing in the digital age, technology, it's meant to enable us and liberate us from all the drudgery of work. And of course, for most of you guys, it didn't. So in the past, we've done surveys. The last Nursing in Digital Age survey in 2018, we focused on district nurses. This one is we opened it up to everybody in the community. We got about 1,200 responses. We found that actually you're a digitally literate workforce. So I quite often have conversations with people, particularly people who maybe work in industry, work in the digital informatics industry, who don't entirely believe the problems of the problems that community nurses have are well, actually it's quite sexist and ageist. So they think because you're mostly older women, you can't handle the technology, and that actually is a load of rubbish. And we've shown that, you know, you're actually a very digitally literate workforce, and you've all got smartphones, and you know that's nonsense. It's their product that's the issue. You're also a very experienced workforce. Most of you working in the community have done so for more than 10 years. And the technology is actually being used really effectively in some places. But some of the challenges that came up were the access to all records and lack of interoperable systems. So you had records that just didn't talk to each other, things just didn't talk to each other. Lack of reliable IT, hardware particularly, you're still using the same laptops you were using 5 years ago, and more appropriate hardware for laptops. So, you know, people were using different types of things for different types of problems that they were having, which was really good. Most of the time, though, it was the system not being fit for purpose, not capturing work or functionality, and people having really poor user experience of that. Some people wanted more training on things, but some people wanted more systems to be more intuitive. So, you know, you take an iPhone out of the box, you can use it straight away. And actually, there's no reason these days you shouldn't be able to do that with most of the platforms you use. We also looked specifically at scheduling platforms, because scheduling platforms were a real challenge to people. And in earlier work we'd done, we found scheduling platforms. So, you know, these things where people get allocated work were actually making people leave their jobs. So that was important for us to look at. So we found that overall, where people were using scheduling platforms, so it's around 750 of those people, those 1,200 people, scheduling wasn't really helping or enabling work as done. So electronic scheduling is not improving the time people have for care, and it doesn't give people enough time to complete all of their work. Few people found it was making more productive use of their time, but most people just didn't really agree with that, and it wasn't really working for them. And in district nurses as a subgroup, we found that particularly. So it wasn't enabling work. Scheduling platforms weren't enabling work. They were actually becoming a barrier to work. People thought, you know, their work should be done. So this is what we submitted to the Parliamentary Health Select Committee to show that actually there'd not really been any improvements in digital enabling this workforce. And we used district nurses because they were in the last, they were in the last group. So, and particularly poor connectivity. By now, you know, it's the 21st century. Most people should have access to Wi-Fi. They didn't have access to Wi-Fi. The hardware was letting them down. The laptops were clunky. The batteries ran out. You know, they couldn't access records. That had improved a bit, actually. It's one of the only things that had improved. That you know, it was easy to access, for example, general practice records. So we've submitted that to and that's been used to look at a strategy for the funding of digital in healthcare. We've opened some discussions with vendors who've been actually, most of the vendors have been really, really good and open to a conversation about how to make user experience better. And trying to make ongoing work to improve user experience, so you don't have to think about what you're doing, and that's really good tech, and helped us really gain a deeper understanding of people's experience using this technology. So thank you to the people that filled that in. That's been really good, and hopefully we're going to use that to influence. So ARRS, the Additional Roles and Responsibilities Scheme. This is England specific, but I think what we're seeing is we're going to see this skill mix happen in lots of different places now. So it might still be relevant to you. ARRS roles, so HEE, well, government via HEE funded a huge amount of other roles to go into general practice. as a workforce modeler, this is a very interesting phenomenon for me because people just don't do that normally. But it landed like a bomb, basically, on the general practice workforce. So you should do really a potential impact assessment beforehand and then one after, but we couldn't do that. So we've done one after. So we went to look at how this had affected you. Thank you, Angie Hack, for giving us the idea and saying this needed to be done. So what we've got is, you can see the sort of roles that deploy. Pharmacist is the most commonly deployed role in this group. So we had about just over 500 people complete this survey, and we only owned it for 3 weeks. So it was quite a popular survey. The other is primarily social prescribers. So you can see there's a big range. I think there are 17 different roles that people can have under ARRS. So you can see that there's, you know, nursing associates were quite popular, and mental health practitioners as well were introduced into physician associate and apprentice physician associate. They're turning out to be quite controversial with the medical community. So it'll be really interesting to see how that unfolds. And what we found, so we were asking if it decreased or, so what we'd ask in the workforce impact survey is whatever this thing is, new jobs, process, technology, whatever, what's it doing to your workload? And interestingly, ARRS hasn't really decreased people's workload. So having more people hasn't decreased the workload. It's increased people's workloads a bit more. And we're going to dig into why that is, because a lot of people have given us a lot of free text on why that is. So overall, it's probably increased people's workloads. This is not uncommon when you introduce a something novel into a situation in a workplace, because there is a form of adaptation. And also, most of these people in this situation have probably never worked in general practice before. So when you've got a new situation, you know, people, even if they're really, really good at their jobs, you put them in a new situation, there is a situational adaptation to that, which the people already in the job have to help those people with. This is not a new thing. It's almost never considered, though, in healthcare. People just think you can just drop people in like they're bits of Lego, but here you go. So we asked people, have you been able to give more holistic care since, you know, because the idea is you've got all this, you've got basically a multidisciplinary team now. Can you give more holistic care? People thought, no, actually, we weren't giving more holistic care, which is quite interesting. So almost half of people thought that, you know, it wasn't particularly helping with that. But a quarter of people thought that it probably was. So, well, this is the big one for me. So any major workforce change, or any major change that affects people's work, people should be consulted on. And virtually nobody was. I'm sure this won't be a surprise to people, but this is really poor practice, you know, and people should be consulted on things that affect their work and their workload. So, you know, we'll write this up. The reason I'm not going to share any of these slides today, and the reason for that is because this is all preliminary results. So the initial emerging issues from ARRS are inequitable pay and conditions. I'm having to teach this person how to work in general practice, and I'm two pay grades lower than them. You know, that was pretty common, and that's pretty poor, actually. Shifting work that colleagues can't complete as a whole episode of care. So what we had, people saying, I like this new colleague, but they can't do all of the work that I did. So they've taken some of my work, but I have to do the rest of the work. And this is a traditional division of labour, and it's not great in safety critical work, because anywhere you get a join, you get risk. So not great. Some roles were more useful than others. So some people liked some of the professions. So mental health practitioners, people thought were great. It was something pretty new and distinctive, something they couldn't offer. It was really adding to the practice. Other roles needed a lot of support and a lot of supervision, and were actually generating more work for the people already in the practice. So we'll kind of explore that in the free text. We've seen a lot of role creep for nursing associates. People in practice people organising care or commissioning care, assuming a nursing associate can do the same job as a GPN. They can do the same tasks, but it's not the same as the same work, because they don't have the experience and possibly education, I don't know, to perform at the same level. So what it's led to, people feel, is more task orientated and disjointed care. I hear this a lot actually from general practitioners now. The taskification of care has become very much prevalent. We've seen disinvestment and devaluation in nursing. We know that. We've seen that. We've seen that with ARRS. We've seen that with advanced practice. And high expectations around supporting roles with no extra resource. So the new people coming in, the existing people have to support. You know, they might not be able to prescribe, for example, but there's no extra resource for that. So that was ARRS. District nursing today, just got a couple of things, because Dave's only just started the analysis. Thank you to I think we've had 1,600 responses to this. Thank you so much if you filled that in. So I thought I'd pick up on the scheduling. So what we're finding is very similar to nursing in the digital age. So currently scheduling, not giving me enough time to complete my work. And we'll keep an eye on this, I think. We'll keep an eye on this longitudinally, because I think it's going to be an issue. And we asked about virtual wards. So we were getting a lot of comments anecdotally that virtual wards were creating work for people. They're having support, particularly out of hours, if you're in an out of hours service. So what we've said is about 838 people said they were virtual wards in their area. Almost half say it made no difference to their workload, but around a third say they've increased their workload. And what we'll do is we'll go through this and look at, see if, because you've also kindly told us if you run, what hours you run your service. So we'll see if this is affecting out of hours people more than people that run a sort of, 8 to 8 service. Unpaid overtime, just to finish on, you work a lot of it. So no one said they worked no unpaid overtime, which out of 1,600 people is actually quite rare. But most of you work some unpaid overtime. And in fact, the one we usually have is 1 to 3 hours. And in general practice nursing, 1 to 3 hours is the most common unpaid overtime. In district nursing, it always shifts right down, actually. So what does that mean? It means you are contributing, just the people in this survey, almost £9 million a year of unpaid labour. So don't be afraid to go and ask for a pay rise. That is a lot of unpaid labour. So 175 grand a week on average. So we've used a midpoint band 7, which is kind of, so it's about 23 quid an hour. So, don't ever, if anyone ever doubts your worth, just tell them how much you're worth in unpaid labour. So where are we going next? District nursing today team leaders survey. So we had 1,542 people. That's quite a lot less than last time. So we had about 3,000 people respond to the last one. It's fine for us. It's enough people to do an analysis, but it's really interesting. And I wonder if team leaders have been lost from the system, actually, because usually you guys are really, really responsive. We've been working with Marie Curie on an end-of-life survey report. So thank you if you filled that in too. Marie Curie and the QNI 70 years ago looked at end-of-life care. And we decided to repeat that work 70 years on to see if anything had changed. You'll be sadly not surprised to see much has, but they're finishing that report and that'll be out soon, I think. It's been really great to work with Ben Bowers on our research community of practice. He's done a fantastic job coordinating that. And if you get the chance, he runs webinars, he does all sorts of things. People think to do research, you've got to sign up and do a trial or be an investigator. You don't. Every time you fill in a survey, you're helping us with research. You're helping us understand this very poorly understood workforce. It is fantastic. And Ben offers, if you want to take a step further, you want to join in the webinars and just talk about research, it's great. And ours kind of Gordian knot, if you like, our intractable problem that we're trying to look at is how many people work in the community, how many registered nurses work in the community. This is turning out to be quite a challenge, I have to say, because nobody knows. So Dave is methodically communicating with lots of different organisations to try and find out if we can get a ballpark figure. We know how many people work in hospitals or employed in the NHS in hospitals, working in the community, because there are so many different employment models. It's much more of a challenge. But we will keep plugging away at that, and we will try and get an answer to that one. So if anyone's got any questions, you can see me, you just drop me an email. I'd love to know your thoughts, particularly on Safer Nursing Community, the tool, and also the workforce standards, because you're kind of saying they are useful to a degree, but is there something about implementation we can help you with? You can also find me on Twitter, X as it's now known, Alison Leary1, and I'd be really pleased to answer any questions. Thank you very much.
Alison, thank you so much for that. I said at the very beginning that you're not afraid to call it out, and once again, you've not been afraid to really highlight some of the key issues and trends in the data that you've been collecting. I think it's really important. The chat box has been flowing as you've been talking. There are some questions in the question box, which I'll bring Fiona in a minute. But one of the things that really struck me was when you were talking around the nursing associates, or the term that's creeping in, non-graduate nursing. And as an academic and as a nurse, and as someone who's passionate about the need for the graduateness of a nurse because of the variety of skills and roles they do, what do you think we need to do in order to make sure that that's not just a slip of term and terminology, but actually doesn't start to creep more and more into policy? What do we need to do as a profession to raise the importance of the graduateness of nursing?
But I mean, there's a lot of evidence about the graduateness of nursing, and people, I think, get a bit nervous about it because, I mean, what the evidence actually shows is if you are a graduate, a new graduate, or a graduate of a few years, or very experienced with CPD, because I think people, I don't have a degree in nursing, and people get really nervous about, you know, are you saying because I haven't got a degree in nursing, I'm not a proper nurse? You know, that's not what it's saying at all. It's saying about the people now, not us 10, 20, 30 years ago, who have got a lot of experience and done a lot of CPD, and, you know, have developed our practice over years. It's about the now, the kids now. Kids, that's terrible, isn't it? The people now graduating, and the critical thinking that's required to do this job, which we have developed over many years of reflection in action, which they don't currently have. So I think we need to take that part of it to say that just because we're talking about graduateness and the value of graduateness, we're not saying people who are not graduates are not valuable. That goes also for nursing associates. This is the return of non-graduate nursing by the back door, you know, but that doesn't mean their worth and work is not valuable. But what it does mean, so the issues that I have with the nursing, and you know, I've written about it many times, is the issues that Asa Briggs pulled out in 1973 in his report. It's exploitative to expect people to work at that level for a much lower pay, and it's also it doesn't do us good as a profession, because if we devalue nursing, everybody else devalues nursing, and that's one of the I think those are the important things to think about. And it's also, I think, because people take it personally, but this is about policy. This is about the landscape that we live and work in. And also, we'll be cared for in as we grow older. You know, I'm not getting any younger. I'm going to need nursing care at some point.
Some really important points there, Alison, and I think it's on all of us within this auditorium today to really contribute our part to ensuring that the graduateness of our profession remains. I was very privileged to be invited to number 10 with the launch of the NHS long-term plan, and the one comment I made to the Prime Minister was, at the peril of this government, if they remove the need for graduateness in nurse education, it would be a backward step for this country and ultimately for our patients and the care they receive. Alice, loads of questions. We've got a bit of time, so I'm going to ask Fiona to come in and just lead us through some of the questions. Thank you, Fiona.
Hi, Alison. It would be interesting to know, Hattie's asked, it would be interesting to know numbers around the wider workforce within district and community nursing, and if DNs are reducing and are they being replaced by other roles?
Yes, I mean, it appears they are. So I just have got this month actually the figures from England from DHSC on the wider workforce, which when I get 5 minutes or an afternoon, because there's a lot of them, I'm going to look at. I've also got a colleague that I'm working with that's looking at care hours per patient day, which is hospital based. I don't think it's done for the community, but it is done for areas like mental health. So what we're going to do is we're looking at, and that data is actually pretty good. And it shows, even though care hours per patient day is an aggregate, which it's an average of an average, not that keen on, but it does show nursing associates, registered nurses, and other all types of other workers. And there is to me, looking at it initially, there is a shift to different workers, yeah. But also I think because we're seeing a growth in those other workforces, you know, and a decline in specialist workforces, you know, I think that is what we're actually seeing. I think that's a symptom of.
Okay, thanks, Alison. I know that the NMC are coming to speak with later about the advanced roles and regulation for nursing. Do you know if the HCPC regulate AHPs in extended roles?
So when we the HCPC did look at this, they commissioned, I think it was the University of Bradford to look at it, who then concluded they didn't need to. But when you look at that report, they made the sort of decision based on professional, professional regulation rather than regulation to protect the public. So when we went to the NMC about the regulation of advanced practice, it was around protecting the public. So we went with the coroner's data that more and more people are calling themselves advanced. They're showing up in prevention of future death notices. You know, it's and there's no standard. And it was one of the reasons you see it in the Nuffield report that the NMC have decided to look at hopefully advanced practice regulation. So HCPC though are, I think, following that very closely. Certainly I'm on the steering group for the NMC advanced practice regulation group, and the HCPC are on that group. So I'm very much hoping that that risk to the public doesn't necessarily stem from the behaviour of regulated professionals, which is what's always been looked at in the past. I think the risk to the public actually stems from the behaviour of some employers, particularly employers outside of the NHS, because that's what shows up in the coroner's reports. So I'm hoping that that's a thing that will be considered. So you see that particularly in areas like mental health and learning disability.
And there's some really good comments around learning disability nursing from Michelle in the chat box as well, which you might want to look at later. But Sarah Evans is asking, is a 6% uplift in GP staff mandated to pass on to staff, but finding many areas are reluctant to reimburse this to their workforce?
Well, it's part of the contract.
Okay,
So
that answers the question. Yeah.
Yeah, I mean it's the negotiated contract, so they might be reluctant, but you could make a claim for it, I'm sure. You know, I'm not a legal expert in terms of pay. I would suggest contacting your union.
Okay, thank you very much for that. And I know that Sam Sherrington's on the call as well, and she's doing a workshop later on the Community Nurse Saver Staffing Tool, which has been mentioned by Phil Hunter as being quite beneficial in Morecambe Bay, and they found it's made a real difference to them. Anne Turner's asking, is there a form of nursing documentation work specific to the NHS, or are they professional wide? Just thinking about RNs in the third sector charities, voluntaries and faith.
So I think certainly the webinar I went to yesterday on documentation seems to be the group are from NHS England, but they're quite a diverse group of people. And I think if there is sort of structure, then hopefully vendors will adopt it, and anybody that uses those systems will then hopefully adopt it. I mean, I think there was a recognition certainly that nursing happens in many different environments, which I found really encouraging. I've got to say, I went to this webinar yesterday thinking, oh my God, you know, it's all going to be about standardised care plans, which fills me with dread. But actually, it was very, very well thought through, and the scope of nursing practice was really embraced. So hopefully it will, even though it might be generated for the NHS in England, it will be of use to more people.
Okay, lovely, thanks. Graham has a really good quote here, but he's saying as a badged ANP in primary care mental health, he's got the position based on experience and having a postgrad certificate, master's, first degree, specialist prescribing qualifications, etc., etc. If he chooses not to do a further master's level qualifications after 32 years in practice, he's asking the question, are we 21st century dinosaurs doomed to extinction and history? Because of, you know, if they're using all these practice skills, they're not using them, and then it's not an advanced practice.
Why is it not advanced practice?
I think he's badged as an ANP in primary care, but he's wondering if you didn't have that further master's qualification with the 32 years of experience, would that leave nurses like him with the skills in the future? Would they be badged as advanced practice, or are they not going to exist anymore? A
further master's? You mean ACP, I guess?
I think so. I'm not sure. I can't say the question.
Yeah. So I mean, one of the things that kind of bothers me a bit about this is that when we look at the ACP has become the benchmark for advanced practice, when the reality is, if you look at the data, I mean, certainly we've got data on about 45,000 people, you know, that is not the marker of advanced practice. You could be in practice for a couple of years and do that ACP masters, you know. So if you're working at master's level, if you've got a master's degree in your specialism, and you've got maybe you might have done the prescribing and the physical assessment or whatever else you need to work at advanced practice at your level, then to me that is advanced practice. I don't know if that answers the question.
I'm not. I think that's probably going the way.
But I mean,
is there a plan for future of national access to all records, including social care? Are you aware of any? I'm not aware of any. I mean, it would be very useful if they did that, I think. Obviously, there's some issues around the banding around district nurse and Fund 6s and Fund 7s, which we've got some information on our website around. Primary care additional roles definitely demand, but the demand is greater than the provision we have to meet, mental health especially. What are your thoughts of future planning? That's from Graham. Sorry, could you hear me?
Was there a question? Sorry.
Oh, sorry. So yeah, what are your thoughts of future planning for mental health services? The primary care additional roles. So the additional roles and responsibilities, there's definitely demand, but the demand is greater than the provision we have to meet it, especially in mental health. Have you got any thoughts for future planning?
It's not something we've particularly looked at, no. I do, from the ARS survey, the mental health roles seem to be the most valued.
Okay.
Because people can come in and hit the ground running, and also because it's an unmet need in primary care. People felt it was an unmet need. So just looking at the initial data, the mental health sort of practitioners seem to be the most valued by the GPNs.
Okay, thank you. And there's another question here from Stacey Planter. Looking at a part of a very small group starting to look at a year 5 workforce plan for community nursing, and listening to you has shown how much it doesn't know. But any advice to where to start and get the executive team to engage in the invisible workforce that they currently are?
Yeah, I mean, I think the issue is that if you're actually, the state of the healthcare at the minute is if you are functioning and you are doing a job reasonably well, then people aren't going to see you, quite frankly. Because the thing that keeps people awake at night, it was interesting listening yesterday, wasn't it, to the nursing leaders and what keeps them awake at night, and workforce, and it's deficit of workforce that keeps people awake, not developing the one that they've got, which is completely understandable.
Yeah.
So I think the first thing is engagement, to be visible. And then it's a lot easier then to think about demand modelling. So what do we need to deliver what we say we're going to do? That's sort of a principle of workforce modelling, really. Start with demand, not with supply. So in the NHS, people start with supply. They don't start with demand. So always start with demand.
Okay, thank you. And I know you've written about this, but the difference between asking the difference, having done the advanced clinical assessment module and the prescribing and still being paid a band 6, what is the difference between the enhanced skills and advanced skills?
Yes, so we've written about this quite a lot. So the issue is that, so if you look at, and I realise a lot of people, although they might be paid on AFC scales, are not subject to AFC in their contract, particularly in general practice. But if you look at the AFC gateways, so if you look at the NHS Confederation website, where all the AFC job profiles are, they have all the gateways on. Page 22 of the appendices, I think, advanced practices. So you could have a look at that and see what requirements it is you need to meet to get through those gateways, and pretty much anybody working in those jobs can get through those gateways to get a higher banding. It's generally around the complexity of the difference between enhanced and advanced is the complexity of practice. So people working at enhanced practice level are good at negotiating with others to get things done, and they quite often have to door hang. So they'll know something needs prescribing, they'll know something needs or requesting, they'll know they don't have the authority to do it. And then when they transition into making those decisions themselves fully and are enabled to do that, that is one of the markers of moving to advanced. But of course, practice is across all 4 pillars: clinical, education, leadership, and research. The other one I've forgotten, which is the one I do, which is quite embarrassing. So, I think you have to think about all 4 areas of those practices as well when you're thinking about asking for improved pay.
Okay, lovely. Thank you very much. I think that's all the questions. Most of those are just comments. I'm going to hand you back to Brian.
Thank you very much for that, Fiona. Really appreciate it. Alison, it would be really worth you having a look at the comments at some point, because there are so many people resonating with some of the responses you're giving and the answers that you're giving, and it's really landing with appreciation to the members of this auditorium. Alison, just in closing, there was something you said at the beginning that is niggling me. It's in my ear, not from a negative perspective, but just because you happened to call it out again. You talked about policy and the fact that nurses were not around the table, particularly in relation to district and community nursing. And I just find that quite shocking. And somebody who's operated in a policy background, when I was chair of the Council of Deans for 6 years and in other areas, what do you think? What's your personal view? What do you think we need to do to prevent that, to stop that, and to make sure we are around the table?
So it's interesting talking to midwives about this the other day. So they say, bring your own chair or build your own table. I think also understanding that it's sometimes, so I used to think that maybe, we weren't being loud enough, which is probably true. We're not being loud enough. But also, it's also beholden to others to listen. So it's up to us to do more, but it's also up to others to do more too. And we shouldn't feel bad because we're not invited, but we should insist on being invited.
I do have an approach of meetings nationally or locally within the trust that I'm a governor for or whatever, and making sure that nurses either are around the table, or if it's to do with nursing, to actually stop the meeting and say, well, why have we not done this? And in my experience, it's mainly naivety or people not thinking quickly, thinking on the hoof. There are occasions where it feels like that might have been a deliberate approach. So I think it's important to stop, raise our voice and make sure that we push that part of the agenda forward for our profession.
Yeah, I mean, I think, you know, allyship is quite important. And if I'm at a table, I ask where the nurses are. A very large health charity has just advertised for trustees, and it is advertising for a nurse because it understands that it is not diverse in its thought, which is really nice to see.
It is. Alison, time is not on our side, but as chair of this session, can I say a huge thank you to you for being prepared to give such a detailed and insightful presentation. And thank you to members in the auditorium for all the comments that you have put within the chat box and for the articulate questions that you have asked to Alison. A fantastic session, and we give you a virtual round of applause for that, Alison. Thank you very much indeed. Thank you. It's now lunchtime, folks. We're going to take a bit of a break. I was emailing the host within this session because at the moment I can't find my view button and I can't see anything but me. So I'm talking to a blind screen. So apologies if there's anyone there trying to get in. But we're about to have a lunch break, and that will be till 1:45. When we come back at 1:45, we got the opportunity to join some round table sessions, and they're led by Queen's nurses, or you can watch the recorded session from Professor Alison Kitson that was here in the auditorium. If you wish to join the round tables after the break, click on the round table tab at the top bar, and you should be able to get to the page and you'll be able to see a list of round tables. There's about 16 round tables that you've got the opportunity to go into. We're doing that in two parts. First round table will go from 1:45 till 2:10, and then you'll be able to join a different round table at 2:15 to 2:40. And we'll put a slide up just to make sure you've got that. After those sessions, we're going to come back into the auditorium at 14:45. So you need to go back to the lobby and click back onto the auditorium. And we'll be joined this afternoon by Sam Foster from the NMC and from Professor Alison Machin, who's the new chair of the Council of Deans of Health. And we'll be really looking forward to what they've got to say. Crystal, given that I'm speaking to a picture of myself, is there anything you want to come in and say, anything I've forgotten at this time?
Not at all, Brian. That was absolutely brilliant. And I just wanted to say a massive thank you to you for taking over chairing of today. And that I believe this is your 7th year of contributing to the QNI conference, 6 years when you were chair of the Council of Deans of Health, which you've only just handed over. And we'll be hearing from Alison, the new chair, later. So yes, that's quite a track record. And thank you so much. And we'll see you after the break.
Thank you for that, Crystal. Thank you, everyone. We look forward to seeing you after the break. Thank you.
You know Brian Webster Henderson. He is due to be chairing this session, and he's having a bit of a challenge getting in. So I will, and we had some roundtables where we've got some delegates who are just coming back from the roundtable, Sam. So if you could give us just a minute or two, is that okay?
Not really role modelling and dispelling the myths. So that was brilliant to hear. I've been very proud.
Fantastic. And that's perfect timing because Brian is now here and I can see Brian. I still can't see you, Sam.
I know. Don't know what's going on. Yeah.
And your camera's on, I'm assuming.
It is on. I'm just having a little look. There's a touch up my appearance box, which I've never tried, but Let me flick a few boxes. It's all on, so I'm not sure what's going on there, but
there's some nice comments in the chat box about coming as newly qualified nurse into community and never looking back. How lovely is that?
Yeah.
I think I'll hand over to Brian, if that's okay with you, Brian. Hopefully you can hear me and you're good to go. We can't see Sam, but we can hear her perfectly well. And I know Amanda's trying to say something. But Amanda's on.
I don't think Brian can hear you.
I think I'm able to hear you now. Brilliant,
okay.
Thank you. A few technical glitches there, but you know, we're nurses, we can cope with anything, can't we? We're multi-skilled and multi-talented. So it's great to see everyone back. I hope you've had an enjoyable time within the breakout sessions, of the roundtable sessions, and a good downtime at lunchtime. For those of you that have just joined, I'm Brian Webster Henderson, Deputy Vice Chancellor at the University of Cumbria, a Professor of Nursing and a Fellow of the Queen's Nursing Institute. We've got a really great couple of sessions coming up, so I'm really delighted to welcome Sam Foster, who's the Executive Director for Professional Practice at the NMC. And you'll remember last year we had some really good sessions around advanced practice and what that particularly meant for those working in people's homes and in the community. So I'll be really interested to hear how things have moved and how the thinking is shaping up in what Sam's got to say to us this afternoon about exploring the regulation of advanced practice. So Sam, a very, very warm welcome to you, and I'm going to hand over to you. Thank you.
thanks so much, Brian. Just checking you can hear me.
Yeah, I can hear you fine.
Good stuff. And you're not missing anything by not seeing me. So I think I've given up on the video, but just going to check that my slide deck's working. So look, both, thank you so much for giving me the opportunity to come and update where we're at. Really exciting times at the NMC. In fact, one of the reasons I was keen to take up posts. I've been at the NMC now for 6 months. Prior to that, I was a chief nurse in Oxford, but been in the NMC, as I say, for 6 months, where I picked up the baton really from Jerry to progress the work. I'm really keen to update colleagues now. Doing this through the lens of the regulatory options that we're exploring. And I hate to say I'm probably going to leave you with more questions than answers, but at the moment that's fine because we are in big engagement session. And I know that Councillor Dean's session after, we've kind of compared notes, so we're hopefully going to flow nicely and complement each other's presentation. So I'm going to give you a bit about the background of the work, our regulatory remit, and I think that's quite key because what we've had to do, as Crystal knows, with our steering group is go back a step and just kind of visit what the regulatory remit of the NMC is. And it's not until you get in that you think, oh, I wish I'd have known lots of this when I was out in practice. So we're sort of revisiting that with steering group members. So it's a good opportunity for me to share that with you. A bit about where we're at with advanced practice, key lines of inquiry, timelines, etc. And obviously, most importantly, how we can hear your voice as well. So just going back a little bit, the corporate strategy for the NMC, which runs up until 25, committed to undertaking a comprehensive review of advanced nursing practice, including consideration of whether regulation was needed. The view was very much that the publication of the new post-reg standards would be a bridge towards the work that we do with advanced practice. And the corporate plan really sort of outlines a bit of a discovery phase, and what that entailed was some commissioning of some independent research. So that was commissioned, the Nuffield Trust undertook that. We also undertook a bit of market research work with a company called Britain Thinks, which I'll come back to at the moment, both of these reports. And I took the outcome of that Nuffield Trust report, which, if I'm honest, doesn't tell any of us on this call anything we don't know, but it does quite neatly bring everything together into a pretty good high quality read. So we took that report to council in May, and I'll give you a bit of a flavour of some of the outputs of that. But what we took was really that this gave us a good sort of, as I say, sort of line in the sand at where we're at. But it also made us think there were several key lines of inquiry that we really wanted to pursue. So in advance of progressing towards a regulatory option, we asked permission from Council to bring in some additional resource, which included the chair of an independent steering group and other colleagues that I'll come on to in a moment, so that we could progress these key lines of inquiry with a view to us going back to an MC Council in the new year with a preferred regulatory option. So the context of this is about public protection. Now we're going to have to find that sweet spot professionally where we don't frighten the public and we don't disengage a whole host of talented colleagues who are practicing beyond the initial scope of their practice. But the driver for this is very much about what's in it for the public protection and the benefit to the public from regulating. The Nuffield Trust identified 4-country variation. This is something we know across the UK, various country-specific frameworks in place. And it highlighted protection of the public with latent risks associated with activity. Now, they looked at things like prevention of future deaths. You know, it was difficult to ascertain where that public protection risk lay, but engaging with professionals through some of the work that they did and through the work that the other company did, there was certainly a theme around public risk and public protection. What they found was a real lack of clarity around scope of practice, limited understanding of the role by the public, real variation in education prep and requirements. And if you've read the report, you'll see a whole host of programmes with a whole host of titles, some which will require portfolio assessment, some which don't. Variation in employer requirements and approaches, colleagues who've attended programmes for advanced practice, maybe not completed them, but continued to call themselves advanced practitioners. Non-registered professionals calling themselves advanced practitioners. I think Alison's probably already spoken, but you'll know from Alison Leary's work that the risks that she has flagged around this variation, and a real variation in role across sectors within health and care. So a bit about our regulatory role. This is established under the Nursing Midwifery Order, so statutory function to protect the public. Organisational structure, functions and activities with our rights and obligations and powers, but we broadly set the standards for education, training, performance and conduct, and we investigate when those standards are at risk of not being met. We ensure that nurses and midwives and nursing associates continue to meet standards through their careers to provide safe, kind and effective care. Registers now actually at over 800,000, with the last qualifying group in September, putting us over 800,000 professionals on the register. We quality assure education and training, and we investigate and individuals and approve learning environments if we're falling short of standards. We know this on this call, but we don't regulate healthcare settings or campaign on behalf of registrants. Many people get confused with the RCN and the NMC. Not something I've ever experienced, but it's something that we do experience. That's just a quick summary. Regulate, support and influence is the space that we're in. And I think what's quite exciting about the advanced practice piece is there's potential to span across all of the pillars that we're considering at the moment. So in terms of definition, you'll know when you get a definition that there's variations across the 4 countries, but the commonalities include advanced level of knowledge base and competence, autonomous decision-making skills, accountability, dealing with complexity, uncertainty and risk. And one of the other commonalities is around the education to master's level. Really, in summary, it's about management of complete episodes of care. Just going to move the box here because it's covering up half of my slide, sorry. But it's about that end-to-end management, that provision of continuity and that reduction of fragmented care. So in recognition of the need to engage with a wide range of views as possible, and we've had our first steering group, we've just had our 3rd project group this morning. It's really difficult keeping the conversation on scope, really difficult steering group with the talented colleagues that we've gathered to support us and steer us, keeping that conversation on scope. But the options that we need to develop for advanced practice will be aimed at upholding public protection, as I say, enhancing public confidence, very much about the proportionate principles of right touch regulation, which is set out by our regulator, the PSA, Professional Standards Authority. It's got to be relevant for nursing and midwifery professionals on our register, relevant for not just the profession, but across the 4 countries and all sectors. A real EDI lens on that, and I'll come back to that in a moment. And we want to engage with as wide range of views as possible. We're not chasing that deadline for the new year, may well stretch that to March, but really ensuring that we do engage with a wide range of views across all of health and care sectors. It's got to be co-produced with contemporaneous evidence. I'll come back to that in a moment, and be pretty ambitious and future-proofed. So we've mainstreamed this into our governance processes. We're focusing on co-production, but with over 900 people on our community of practice now, we're trying to get this into manageable group sizes for the right discussion, building consensus and resolution so that we can pursue those opportunities. One of the opportunities is pursuing the commitment for joint regulatory activity, and we've got a cross-regulatory group meeting again, in fact, on Friday, first meeting in September. It's a really, really great meeting, really energising. I hadn't appreciated the good relationship that the NMC have with other regulators. Whenever we put something out, there's a shout from paramedics, therapists and others that, you know, the risk of having a 2-tier system where nurses and midwives are potentially regulated and other professions are not, requires a conversation. So we've had our first meet where we have a commitment to issue a joint statement and a definition of advanced practice on behalf of the other health regulators, which I think is a real step in some ways. How can we regulate something that we haven't defined? So I think that's going to be really key. We're meeting again on Friday to look at progress and be keen to share that with colleagues across the profession. As I said, from that initial Nuffield work, we developed 9 key lines of inquiry. I've got some slides on that we're working through at the moment. What we did was we went to our chief nursing officers for the 4 countries, and we've asked them to nominate a nurse and a midwife from each country to work with us, to work with the NMC standards team to really put some challenge in, and to be the leads to engage across their respective countries and to represent some of the engagement work that we want to do with the public. So as I say, planning to go back in January 24 as a gateway point with a preferred option for regulation. I might push that to March. It just feels quite tight. You know, I said this morning, the mince pies are already in the supermarket, so it's feeling a bit pressured. So we might just stretch that to make sure that we get everybody's voice heard and that we genuinely do co-produce this with the profession and with the public. So the options that we've got, if you like, in the bag, this is a kind of distilled version, but we can go from, and my brilliant colleague Anne Trotter, who many of you know, she describes this as kind of skimmed milk through to full fat regulation, and we've had all sorts of milks put in between here, but we can retain the status quo. We're reluctant to say do nothing, but retain the status quo, which it feels like the profession doesn't have the appetite for. You know, it's pretty ungoverned at the moment, and retaining the status quo is an option that we're exploring and needs to be on there. But I think whilst we go round and round in circles on the other options, this isn't one that's going to have lots of support from the profession. We can look at using the existing mechanisms that we have, which are short of regulation, bearing in mind, of course, all of our professionals are registered and regulated already. So what have we got in the toolkit? Revalidation, etc. We can look at joint approaches that may emerge from the work that we're doing with colleagues, with other CNOs and other non-medical professions. We could look at introducing a test of competence. We can look at the credentialing that many organisations offer, or we can opt for that full-fat, full-scale regulation where the NMC set the standards, approve those programmes and monitor them. So they're the options that we're considering with the key lines of inquiry work that we're undertaking. So what do those key lines of inquiry look like? So we've got, as I say, a really pretty impressive standards team. Actually, they're in my group, and they're really, really impressive team, working really closely now with the seconded nurses and midwives, and also with colleagues who are suggesting names. It'd be great to have, you know, more names and colleagues for us to work with, and having conversations and really shaping the outputs of those key lines of inquiry to advise the steering group in direction towards that preferred model for regulation. So we're looking at comparative analysis of the frameworks across the 4 countries, whether there's a potential for a UK-wide framework. looking at models in other countries, opportunities to identify elements that could adapt into the UK context. Looking at scope and considerations, including generalist advanced practice. Steering group this morning, or project group really, we looked at the task shifting rationale and those tasks that were formally undertaken by other professionals, and really looking at the pros and cons and otherwise, and the history really behind advanced practice. Looking at what supervision and assessment and CPD arrangements there are out across the 4 countries and internationally. Looking at the approach by the professional regulators. We think it's important to look at some sort of economic evaluation of cost benefits to these roles, particularly in light of informing and supporting 4 country workforce plans. Looking very much at those risks and benefits from a public perspective of each potential option of regulation. And key line of inquiry 9 is something that we're looking at the moment. That might be a phase 2, but as I said, through that EDI lens, we're really aware of the consideration of the impact of advanced practice, particularly for CPD on internationally educated nurses, and some of the nuances around education and training funding, visa impacts, and other things that I frankly wasn't aware of before coming into post. But we've been shaping up, and we have a colleague who's willing to work with us on key line of inquiry 9. So really keen that people are at the heart of this. We have a public advisory group, and we're really lucky that's gone very well. We've had our first meeting. We have our own public voice forum. And as I said, we've got the 4 countries nursing midwifery advisors who are engaging with members of the public. Lots of organisations, long-term conditions organisations, cancer charities, anyone that will allow us to go and engage with them really. But what's come through when we go back to council in the new year is that strong public voice, and some criticism levied on me by my comms and engagement team is whenever we talk about advanced practice, we generally talk about the benefit for our profession and role progression, which I think is so implicit, the benefit for patients. We sometimes lose that in our enthusiasm to talk about advanced practice. So it's that voice that we need to bring through very much so when I go back to council in the new year. So progress to date, colleagues will probably know from our announcement, Kay Fawcett has been appointed as our independent chair. We've got stakeholders from across the UK. We had an inaugural meeting beginning of September, which was great, noisy, buzzing, and we've got our next one coming up, which we've chosen to get a bit of control. It's going to be a bit more speed dating, a bit more breakout, and really start sweating the issues that are coming out of the key lines of inquiry. We're exploring those with the 4 nation chief nursing officers, midwifery officers, leads, and colleagues from across the 4 countries and other organisations. And as I said, we've got our joint regulatory roundtable where we're regrouping on Friday to progress this statement and definition. We've got a community of interest, which I'll give you details of in a moment. Over 900 people have joined from across all sectors, and that's where it's the opportunity to keep updated, to join in with opinion pieces, webinars, and generally get in touch with us to put people forward to ensure that we've got good representation and engagement for all of those key lines of inquiry. We've developed a specialties group so that we can hear across specialties, and we're also asking for researchers to be engaged with us to raise awareness of the potential research opportunities that this gives us. And we need to work with some of the internal activities that we've got, opportunities for regulatory reform. You'll know that the GMC are ahead of us. They're looking to regulate the physician's associate, the anaesthetic practitioners. So the NMC are building their rules, I guess, of what we want to put forward, and the sort of operating platforms that we would like to have going forward under regulatory reform. And as I mentioned earlier, really trying to support the ambitions of the four nations workforce plans. So just in terms of timelines, we were in Cardiff last week. We did a update on that. You'll be really pleased to know that I used primary care community nursing patient stories to illustrate. It's really important to bring this to life. So we top and tailed our update with one example of sort of role definition and confusion from employer, but we ended the presentation with a very positive, seamless pathway with huge benefit to patient with a long-term condition, you know, end-to-end care of a patient with some referral in for some specialist advice, but the care sitting very much with that advanced nurse practitioner out in the community. Progressing with key lines of inquiry. I'm chairing the internal project board to keep us going so that we're ready for updating our steering group, that, as I say, are steering us towards what that preferred regulatory option looks like, drafting those options towards the end of the year, and really trying to keep our communications, talking to as many people that will listen to us, so that we can keep the conversation going, and then land on a preferred option. And then the real work will start, because we'll start working through bringing that to life with phase 2 after we've taken that to council. So lots of opportunities for colleagues on this call to join us. As I said, I think from the specialties group, from your respective 4 countries, nursing or midwifery advisor, from a research perspective, but very much that's the details. You can come directly to me. I can pass you on to colleagues, but the advanced practice at nmc-uk.org is a great portal to go into to get yourself familiarised with where we're at. All of our documents are on there, and we really would welcome you know, as much engagement as possible and as much involvement as people can spare. I don't know if I've gone through that too quickly, but I did want the opportunity to widen that conversation, Brian, if we can, because I can't keep my eye on the chat box and present at the same time. Should have brought a friend with me, shouldn't I?
Sam, that's absolutely fine. Thank you for that. I really appreciate it. As you would imagine, there has been some stimulation in the chat box. There are some questions in the question box, and before I bring Fiona in, I'm just going to encourage colleagues in the auditorium, if you do have questions, we've got a few minutes left for Sam, do pop them in the box. And Sam, just to kind of stimulate and get things going, I've got just some couple of questions to help our thinking. And I do think that if there's one area in my career that seems to stimulate a lot of diversity and a lot of conversation, it's advanced practice. So I totally hear what you say about the challenges of trying to keep the group on scope and within scope. And, you know, good luck to you with that one, because I think that is a real challenge to do, because there's such a variety of views and opinions. 2 things really struck me. One was around the variety of roles and people you're aware of across the country who may not be educated to master's level, but may call themselves advanced practitioners. And within the options that you're looking at, are you looking at approaches within them to kind of bridge people to move on a journey rather than just expect them to meet a set of requirements or a test of competence or whatever approach we take? Are we looking at some sort of bridging approach within the options?
That's a great question, Brian. I think so. If Anne Trotter was here, she would say, Brian, we are Switzerland. And I think that, you know, the steering group we've got now are the steering group to steer us towards the regulatory option. If the regulatory option is full fat regulation, then the steering group will need to change and become much richer with educationalists, because they're the kind of conversations we'll need to have. Because if we go with status quo, or let's look at something different with revalidation, then there won't be sort of a regulatory bar to meet, if you like. So it's really difficult because, as you say, we've all been talking about advanced practice for so long, haven't we? We can all veer off, but I think at the moment we're looking at what do we think the preferred regulatory option is, and in the event of that needing an education standard, then we'll be calling in our educationist colleagues to say, right, what are the options? What are the unintended consequences? What's the intent? You know, where do we start, really? I hope that answers it.
That's a really helpful answer, Sam. And maybe if I could just stimulate a little bit of devil's advocate, I would think it's a really good opportunity to bring in an educationalist now to help inform and unpack those options, because all of them will require some element of learning, possibly, even from a revalidation perspective. There's an element of how you reflect that in your statements to meet any competencies or any regulatory framework. I would have thought there's a missed opportunity by waiting to bring in an educational view, but then you might expect me to say that because I'm an educationalist and a nurse, but I do think there could be a really added value to looking at the options from an educational lens now and not waiting until seeing what option you go down, but just a view.
No, I think there are educationists around the table, council of deans around the table with us, and others. Having said that, you know, if we need to bring other members on through the course of this 6 months, completely open to that as well. And interestingly, one of our actions this morning was to recirculate steering group members, just so, because you know what it's like. There's all, you know, there's this names, there's people that you recognise, and then we just need to refresh ourselves. And as you say, just make sure we've got the right ingredients around the table. So look, what I'd do is I'm going to share that list with you for your view as an action. And
right.
You can tell if you think we've got anything missing, because what we, you know, the credibility of this is really important. What I don't want to do is get to January and people say, but you just haven't looked at it through this lens. So let's share that.
And Sam, finally for me, before I hand over to Fiona, I thought the key levels of inquiry, the 9 areas, were really great and really encouraging to see all that exploration and following through different thoughts, perceptions, experiences. I guess the one thing that it kind of left me with was, gosh, there's a lot of lines of inquiry there with which will bring back a huge amount of data, and how are we going to help that inform the options? Because we could end up with a massive amount of information, and before we know it, we don't have a route or a methodology to help inform the options. So is that something you're thinking about as you're looking at those 9 lines?
Yeah, for sure. And I mean, you know, I kind of commended the talent of the guys in the standards team. You know, I really can't overemphasize that. They are absolute expert, you know, kind of policy and standards colleagues. I'm so impressed with some of the outputs so far, and we're reviewing progress on them. I think it could be a real move to actually start sharing some of the briefing notes that they, you know, just to see the level of and the caliber of work that's going on behind the scenes around these key lines of inquiry. And this morning when we kind of had some feedback just on 2 specific ones, I think that we should just keep that conversation going and post sort of progress, you know. And the team are perfectionists, and I said, look, this is work in progress. Actually, the richness of posting where we're at, so that people can say, but have you thought about it from this lens? Again, it is kind of maybe a takeaway that you're making me reflect on now. So I'd like to share that, just sheerly from the quality of the work that I've seen so far as well.
Thank you, Sam. Enough from me. We've got a crowded auditorium. So I think I'm handing over to Fiona, who's just going to pull out some of the questions from colleagues who are in the auditorium this afternoon. Fiona.
I will give it a go. There's quite a lot. I'm just trying to unpick them a little bit. And just there's a question around, obviously, advanced practice has been around in lots of different countries around the world at various times. Are the NMC looking at any other areas for what they're doing? And also to some clarification on whether this is a regulation of a title or a level of practice.
Yes, I think I heard that right. And sorry, because I'm looking at our own chat box, and what I'm also really pleased to share with you is I have brought a friend with me, actually. Julie Bliss, who's one of our very senior nursing advisors, is having a look at the chat box as well. So I'm going to ensure that she's kind of second pair of ears for me. Going back to the key lines of inquiry, we're asking for challenge sessions. So, you know, offline we'll work on how we can get updates on those key lines of inquiry up, and also keep it open so that people can either just post a challenge or be engaged in a conversation. So I just wanted to note that. I might have whizzed through it too quickly, but it is an international lens that we're looking at on advanced practice frameworks, approaches, regulation. So hopefully that's all captured. And I just wouldn't mind you repeating your second question, if that's okay.
Is it regulation of a title or a level of practice? Because
Well,
I think
that-
that we had Angela
therein lies
Leary.
the conundrum. Yeah, you're right. There lies the conundrum. And I think that's why we're keen to get this definition, because, you know, the key question is, what are we regulating? So, and that conversation changes depending on who's in the room. And we had a big debate, Julie's on the call with me, but we had a huge debate about what is scope of practice. Have we even ever defined scope of practice professionally? So that is part of our key lines of inquiry, as you say, whether this is a title or a level of practice. It's heavily weighted towards a level of practice.
And I think on that links into another question of obviously you said you're involving lots of specialists, so I'm just wondering what the definition of specialist is as well, because obviously you've got community nurses, there's a lot of different specialisms within community nursing, and there's lots of specialisms within hospital nursing as well. So and obviously from a QNI perspective, that having the community nursing aspect in there is really important.
Yeah, so I mean, I won't bring it up now, but I've got a breakdown of the 900 people on the community of practice, which is every field, every sector. So that's really great to see. And as I sort of go back to what Anne would tell me to say, you know, we're Switzerland, it's whoever calls himself a specialist at the moment, because that's another session, isn't it? But really engaging with the profession, I think, so that we can just ensure that we have that part of the debate in this debate.
Okay, and then there's somebody else who wants to play devil's advocate, like Brian. This is Graham Poulter. I do want to play devil's advocate as a master's graduate and a postgrad and practicing as an A&P in mental health, but don't want to do another master's program. I do end-to-end care and I'm supervised and have supervision at consultant level. Where would full regulation leave someone like me? Could this force people out of posts, for example?
Well, that's the thing, you see, because at the moment, in all honesty, it's employers that are setting the direction for advanced practice. You know, that's why we've got such variation in titles and, you know, vicarious liability and job descriptions and, you know, such variation. So, and that's why we need to get this, as I said, this balance of risk, that we don't want to frighten the public that unless, you know, you meet this criteria, you shouldn't be practicing at this level. Equally, we don't want to disengage with people that, you know, will meet whatever the definition is. So I think it's a bit to be continued, because what we need to do is set that definition, and then we need to work through what the consequences are. And as Brian says, that's where, if we go full fat regulation, we'll need to have those debates. As you say, is there, you know, what are the kind of academic levers that we have in accreditation of prior, you know, this is your bag, Brian. What have we got when the bar gets set and there are several thousand people with a variation of title of their programme? You know, I guess one of the things I'd say is I've got a master's in advancing critical care practice, but I would never call myself an advanced practitioner. I have prescribing and the like, never practiced, you know, at an advanced level beyond a critical care nurse, but some people would. So that there's something about the variation that the employers have enabled that we need to grip and have a professional conversation about. But there would be no intended consequence that there would be a kind of, you know, I believe NMC stamped program that people would have to aspire to be at. This is where we'd have to have that, you know, wider educational conversation around, we're going to set these standards, or this is the credentialing that we're going for, or, you know, we're looking at all those options, including status quo being one of them.
Okay, so then that sort of answers.
I'd love Brian's view on that, because imagine we said, Brian, okay, look, the preferred option, loud and clear, is full fat regulation. We set the standards. I mean, what would be your kind of advice for us to consider? Just kind of top three things, maybe.
Well, as the conversation was going on, I was thinking around some of the challenges that we have created for ourselves within the higher education sector. We're not perfect in this by any means, because of the lack of regulation. So we have had the ability to develop courses. There's none are similar really all over the country. There might be similar components, but they're all allowed to be different. And therefore we have contributed to developing with employers what we think they need, responding to it, and then maybe giving it a title. And that has actually added to that complexity, but in the vacuum of a lack of perhaps regulation or guidance or protocols. So some of the options that I can see that you've looked at, I wonder really how much of an option they are. I'll give you an example of that, Sam, where you've said that one option might be to introduce a test of competence. I'm now trying to equate in my head how that matches A, the definition yet to be defined, but E, the thinking that actually advanced practice should be at master's level. So if I'm working as an advanced practitioner, don't have a master's degree, but I've done some CPD at degree level, and I'm now working in a role defined by my employer that's advanced practice, how are we going to do a test of competence to meet some of those variations? Sit a test at master's level, someone sits it, passes, but they don't have a master's degree? Or is it actually the full fat approach, as Anne calls it, where we make people have to achieve certain requirements? And some of those things have to be balanced around the deficits we know we've got in the workforce already, the NHS long-term plan and its push towards advanced practice. So each of those options, I think, has areas of risk and areas of challenge about it. And that's why I think there's a real need to have an educationalist voice in that section now. Yeah,
absolutely. And I'm just having messages from afar. So Julie Bliss, who I mentioned earlier, Julie's a community background. She's saying, my understanding is the consequence of any decisions would consider those currently working as advanced practitioners. This has been done previously, for example, when district nursing SPQ moved to degree, she said, a very long time ago. I mean, I said I was going to come with more questions than answers. You can see, can't you, where these debates need to go for us.
Fiona, any further questions?
I mean, there is one, but I think you're going to turn into Switzerland because somebody's asking, what is your preferred option for maintaining and setting standards and regulation?
For me, I go round and round in circles, genuinely. I think status quo is not an option. I think, you know, because that list of 6 is just the genuine options we've got. You know, it is what it is. And one of my colleagues said yesterday, well, look, you can't do a test of competence unless you set the standards. So, you know, that's flawed on its own. So, you know, this is genuinely open for debate. This is engagement time. There's no fixed view. Even Paula McLaren, who's working as GP practice advanced nurse practitioner, she's also the senior nursing advisor for this programme. She said this morning, I'm going round and round in circles myself, you know, which is good because everybody's listening to everybody's views and taking themselves, you know, up and down those options.
Okay, thank you.
Thank you, Fiona. And Sam, thank you very much for coming along this afternoon and speaking to the auditorium here at the QNI around where the NMC are with the options and its approach and its consideration. I think what's been heartwarming.
Is there a way, Brian, that we can grab the question? Can someone screenshot the questions for us so that we can weave it in? Because there are others that I could have answered, or I just need to make sure we could answer in the event of those coming up. Because, you know, those key lines of inquiry are a kind of headline. What sits beneath them, for example, is the 4 pillars. You know, there's a whole, you know, I can pretty much feel like we've covered it, but it'd be good for somebody to be able to get those questions to us so that we can just test ourselves on, you know, the questions that are coming back from this conference, please.
I'll let one of my QNI colleagues answer that. I think Crystal's come off mute.
Yeah, we will definitely do that, Sam. We do that for all of our speakers, so we will definitely do that and we'll send them to you.
And QNI are on our steering group, so, you know,
yeah,
there is a voice there, isn't there?
There is.
Absolutely.
Sam, thank you for that. I just want to throw in a last summary point, because I think you made it, so it's not to be controversial, it's just to echo what you said. And you said, well, one of the really important things here is what is it we are regulating? And for me, that definition is crucial to the direction of travel. And because of the plethora of roles and views and opinions we've got across our 4 nations of the UK, the definition from a regulatory lens is going to be absolutely crucial to the future pathway of what the shape of that regulation may look like. So thank you for coming this afternoon. It is really warmly appreciated. And colleagues, I'm sure you'll join with me in a virtual round of applause to Sam and thanking her for her content and input this afternoon. Thank you, Sam.
Thanks so much. Look forward to hearing from colleagues and listening into future sessions. Thank you, Brian.
Great, thank you very much. Thank you, colleagues. I hope you found that really helpful. It was good to see the chat box flowing and people sharing examples from a personal perspective and from an employer's perspective and sharing your own thoughts. So really great to see that. It's always my experience at the QNI conference that that's what you get, people who are really keen to engage and involve and share their own experiences and thoughts. I'm just looking around to see if we've got Alison now in the auditorium.
Yes, I'm here, Brian.
Hi, Alison. In that case, we'll kick straight on ahead. So it's really my great pleasure, and it feels a little bit odd because any time I've been here at the QNI conference, I've been as the chair of the Council of Deans, and now I've handed over that baton to yourself, which is fantastic. So a really warm welcome, everyone, to Professor Alison Machin, who is not just the chair of the Council of Deans, but is also the Dean of Health at Edinburgh Napier University, and has previously worked at Northumbria and held a variety of roles. Gives of her time, Alison, I'm going to embarrass you now, gives of her time as a trustee in some local organisations and national organisations across the UK, so has a lot of experience and ongoing interest in the shape of care across the UK. And Alison's going to talk to us about the advanced practice landscape and give a Council of Deans perspective in relation to higher education. So Alison, thank you for coming, and over to you.
Thanks, Brian, for that warm welcome. Much appreciated. Now, Adina, are you sharing my slides or am I going to share them?
I'm happy to share it for you.
Okay, thank you. So Brian gave me a quick resume there, but it's probably also important to say that I'm a nurse and a health visitor by background as well. So community nursing and the community context of care is dear to my heart. And also to share that my daughter has just qualified as a learning disability nurse and got her first job in the community young people's and children's team. So I'm absolutely delighted about that as well. So great first destination post for her. Anyway, I'm here to talk about the Council of Deans. What strikes me is you're probably going to hear things that have already come up in the conversation. And I think all that does really is triangulate the complexity of this landscape and perhaps the different lenses, perhaps the different dimensions or the different priorities different organisations are given to the ongoing debate. So that's my plan. I'm also going to, the first couple of slides, just tell you a bit about the Council of Deans of Health, because there might well be colleagues on the call who may have heard of us, may not have, but just so we're clear as to what we are as an organisation and who we represent. Next slide, please. Okay, so we're quite a big organisation, and we've got 105 university members across every region and nation in the UK, and we're growing. 2 more just got approved at the trustee board last week. And when I say members, it's actually the universities themselves who are the members of the organisation. So then they bring with it all of the people who work in the organisation in the sort of health schools mainly. And then also by default, all of the education workforce out there in clinical practice who support the education of the students, both at pre-registration and post-qualifying as well. So many of you on the call will be in that scope and no doubt linked with a partner university who are probably a member of the Council of Deans of Health. So we represent faculty, schools, departments, whatever they're called, who teach nurses, midwives and AHPs. Essentially, that's the scope of our organisational charitable scope at the moment. I always have ongoing conversations about how far we extend beyond that, but that's where we sit at the moment. So really, our members are important stakeholders in this conversation. We teach 97+% of all of the students in our disciplines, and 97.7% of all of the postgraduate healthcare students as well. So a big collective voice. The vast majority of people who are leading those organisations at departmental school level, like me, are also registrants themselves from professional background or one professional background or another. So committed, invested in the future of the workforce and the future of our students and the future of the healthcare services for the public, if you like. So it's a big endeavour. Next slide, please.
So I'm new in role as chair, as Brian said, and we've also got a new Chief Executive Officer, Ed Hughes. So he is responsible for leading the staff team at the Council of Deans of Health, and Ed is often the person who will be the first call stakeholder in some of these really important strategic meetings and discussions. So Ed and I were very closely together. You may have met Katerina Colliver before, who worked closely with Brian. So now it's Ed and myself who are charged with the business of leading the organisation. So my primary role is the governance of the organisation, and I chair the trustee board and make sure that the strategy is as it should be, and that the team have the resources that they need to do their job. We have policy groups which are represent all of the universities in all 4 nations, and I sit on the Scotland Council of Deans and was convener up until I took over as chair. So very much have a Scotland and England lens on my work, and I'm getting to grips with the other 2 nations as I go along. And we also have member-led groups. And they are quite big groups, and there will be opportunity for more people to join those groups as we go forwards, which is starting to think about how we do that in the council. And they focus essentially on research, quality, diversity and inclusion, pedagogy and innovation, regulation and strategic policy. So all of the key things that are the priorities of organisations who are leading this big endeavour, this health education programme of work. Next slide, please. So coming to advanced practice then, the reason why I'm here today. So it was last year the NMC announced their plans to consider the regulation of advanced practice at our annual Council of Deans NMC meeting. So we are regular partners in the conversations around all of the regulators' discussions around any developments, very close working relationship with the NMC, the HCPC as well, and would like to be at the forefront of these discussions, and I think that's absolutely essential, as Brian's been talking about then on the previous presentation. And Sam and I had a pre-meeting, a pre-conversation about these sessions, just to see where the alignment was, where the differences might be, and I think it's just the different way that we're looking at it. But you'll quite clearly see shortly when I share with you some of the questions our members have, that they're also the questions that have come up in the chat today, and they're also the questions everybody's asking. So we're all asking the same questions, which has got to be good for dialogue and moving forward together. So we have our own Advanced Practice Council of Deans group members, and they can act as a reference group in the collaboration. Currently, Ed sits on the steering group that Sam talked about at the NMC. So we do have a seat at the table in the steering group, and I would suggest going forward that our Advanced Practice Council of Deans group need to be much more connected into some of those other conversations around the different strands of activity, looking at the different models. And I can pick that up in a conversation with Sam after the event, most definitely. And just out of interest, Advanced Practice is also on our agenda for our new partnership working with our Australian Council of Deans partners. And we've got an MOU with them, which is just about to be signed to firm up the relationship. And part of the reason we're doing that is so we can learn from each other and think about what's been done in other areas, what have been the challenges and the issues. And I was on the call with Alison, the recorded call with Alison Kitson earlier on, listening to her experience in Australia. So that was quite useful just to think about that. And the issues are the same the world over. It's the context that's different slightly. Next slide, please. So where are we at on advanced practice from the Council of Deans? Well, we had we've got the group, but we also had a big discussion session at the last Council of Deans members event. And what was very clear was that there are really quite strong opinions, varied across members in terms of the pros and cons of regulation. And that's not surprising, really, because the leaders in the room were from a nursing background, from a midwifery background, from OT, physio, podiatrists. You know, it's different, just a different way of looking at things and thinking about just the complexity of the regulation across all of those professions. And, you know, why do we need it? You know, is what we're doing not okay for EHPs? Do we have to have it? What about nursing and midwifery? A really complex discussion, arrived at no council position. We couldn't possibly put out a statement on what we think it should be, what we think the level of regulation should be. We're not at that place yet, and we're just keen to be part of the discussions, both to respond to things, but also to inform the discussions and the art of the possible, if you like. But given where the NMC are and all of the work that's being put into this, we are working from the possibility that there's going to be some sort of regulation, even if it's just skim milk regulation, and it's thinking through the implications for our university members and all of that, the opportunities as well. Next slide, please. So, well, you'll not be surprised to see these, because this is what we've been talking about already. How can we possibly achieve a standard shared definition of advanced practice across all of the professions? Is it possible? It'd be great if we can, but let's see where we get to. We might end up with something that's so generic that it wasn't worth doing in the first place. So there's a challenge. Let's see where we get to. What about the people already in these roles? What are the implications for them? How will that be managed? Will that be the responsibility of employers? Will we need universities involved? Will it just be the regulators thinking through all of that? Might there be a future direct route to an advanced clinical practitioner without needing to be an NMAP in the first place? Whoa, that's a mind-blowing one, but potentially, at the minute, it seems like all cards are on the table, doesn't it? So let's have a look at all of this. And then, I know this is the view of many, is when we're talking about advanced practice, are we really talking about a level of role rather than trying to pin down role parameters and job descriptions around all of this? So you can see this is exactly the same space as we've just been talking about in the last session. Next slide, please. Again, we've just been talking about this. Is advanced practice regulation going to be... Oh, I think we've moved on a slide. Go back one. Yeah. So is advanced practice regulation going to be applying to the enacted role in practice, guidance for employers, job descriptions, role descriptions, that sort of thing? Will it be an education preparation program with standards for education be monitored, or both? And that's really that scope that Sam was talking about in terms of the scale of the regulation. There was some conversation from our members about the existing regulatory frameworks, the credentialing, for example. Are some of those processes not satisfactory enough, and could we not just apply them across the piece? Or will it be statutory and really nailed down? What are the implications for other advanced practice professional roles if one regulator acts first independently of the others? And I was really heartened to hear from Sam, both before this session and in the session, that there are really positive conversations happening between the regulators around all of this. And it would be great, wouldn't it, if everyone was inching forward together, but it would be difficult. And how can we ensure that all stakeholders at all levels are involved in the conversation as well? And again, I can see the programme of engagement from the NMC, but what about the wider MAPs? What about the wider AHPs, sorry, in the mix of all of that, and making people feel like they're part of the dialogue is going to be the challenge. Next slide. And then just to add to the complexity of it all, if the discussion and development is mainly focused in one nation, often because it's the biggest, often the conversations start in England and then filter out. And that's not necessarily always well received. I know that from my current practice in Scotland. This needs to be thought through. And again, good to hear that Sam's talking to the CNOs and the CMOs in all 4 nations, that they're involved in the early sort of steering discussions around all of this, because that's going to be important as well. However, what about the local context of implementation? If we get to a point where we've sorted all of this out, there's still going to be different contexts for implementing the role, and there needs to be flexibility, in my view, around that. There needs to be a core definition if we're going to get to that space, but with enough flexibility to meet the needs of the people in the services that are being delivered. I feel like I sneaked into a session earlier on, one of the roundtable sessions, and it was a really good, interesting session. Grace, I don't know if Grace is still on the call, was explaining about her role as an ACP in the community context where she works, and just at a very micro level, reflecting back this complexity, the work that's been done across the NMAP group, also involving the medics and various people to work out in their particular trust, in that particular setting, what's going to be the role of an ACP. And it was fascinating. And then somebody asked in the question, it was from a different trust, and well, what did they think about that? Because actually the ACP role in their trust was something completely different. So that was just played out at micro level, and that's happening now on the ground. And we're talking about it at a national strategic level, and somehow, somewhere, all of this has got to be sorted out. But also there's opportunity in with that to share best practice and innovation, and the council can support with that. Next slide, please. Well, I could spend ages on this one, but I won't. My particular interest is around interprofessional learning and working, and also professional role identity. When I did my PhD a while back now, it was about professional role identity of health visitors. But it was actually in the context of the title shifting a bit when the Nursing and Midwifery Council name changed and the health visitor was dropped off the main council name, and how people were feeling about that. The biggest thing I want to say is role titles matter. They matter to individuals in terms of their sense of self. They matter to individuals in terms of how other people see them in the team. But most importantly, they matter to the public and the people that they're working with. We need to get this right. Really need to get this right, and I sincerely hope that we can get to there. But in the implementation of any change, that professional identity piece and where new roles sit in the context of the multidisciplinary environment we all work in, I think is absolutely essential to consider. Retention and recruitment is the big thing for our council members, universities, big challenge at the minute. We know that it's a struggle to recruit people to the professions and retain people in the workforce. And I think the advanced practice agenda has got a real draw. If we can get it right, if it looks like it's a seamless career progression from pre-registration through to a point with very clear lines for different people from different fields, different contexts of practice, and there's a real potential for this to be a whole-scale recruitment retention strategy, and therefore recruitment strategy as well. So that's an interesting one. And then essentially, how can the council support the 4 pillars of advanced practice is the work that we can do to help our colleagues in practice and to help the universities who are delivering education programmes to colleagues in practice as well. Next slide, please. I've just put a slide in here about different things that the council are involved in at the minute. Many of the resources on the Council of Dean's websites are open access. We do a lot of webinars and seminars that are open to everybody within our member organisations, but by default they're open access. So if anybody's interested, you can go onto the website and have a look at the work that's happening with advanced practice. You can see that there's a big strategic priority around research and research careers and clinical academic careers, and I think there's a real tie-in with the advanced practice scenario there. A lot of support for innovation around pedagogy, and a lot of people on the call will be involved in practice education and thinking about doing things differently with the students that they support, as well as in their own practice. We've got a big focus on leadership. The whole organisation is about supporting the leaders of higher education in our disciplines, but also a focus on student leadership. And I'm sure some of you have heard of the Burdett funded student leadership programme that we have. Next slide, please. So furthering our work, we're very keen, all of us, members and the organisation, to work with our partners and stakeholders to continue to raise questions, push the dialogue forward, perhaps come up with some innovative solutions as well, and just be part of that. And just a final point from me really is just to say that along with the NMC, the QNI are really important friends for the Council of Deans in this space. We're really committed to supporting, the future development of community nursing in all its guises, including advanced practice. So I'm very happy to be part of those conversations. Thank you for listening. Happy to take questions.
Thank you very much for that, Alison. Thank you for giving a perspective, and I totally hear you and totally understand, as you would expect, when it's difficult to get a Council of Deans perspective when our members may have different thoughts and considerations themselves. One of the earlier questions pinned Sam down around what would her option be. So I'm going to do the same to you in your guise, not as the chair of the council, but just as Alison, the nurse and the health visitor. What do you think we should do with advanced practice? Do you think it should be regulated? And if so, which option do you think would be most appropriate, just to stimulate conversation?
I suppose you can only ever give opinion as to where you are at this moment in time. And then every time you engage in discussions, you become more informed and even change your mind. It feels like it's a level of practice to me. We've got too much existing complexity in the system to unpick if we go down the road of having a single role descriptor that everybody tries to fit into. Whether that's just a temporary move, and and as things move on, things might be different, but there's just such a complexity of service provision, complexity of need in the people who use the services, what they might need from an advanced clinical practitioner in a learning disability community context compared to an acute intensive care context. It's just too big, I think. So I think it's about a level of practice, but whether there are still standards at that minimum level of practice that can be regulated, and that people, there's a certain level of education, certain perhaps role characteristics or something that are a level that feels a bit more comfortable to me than going through a single practitioner type lens.
Thank you for that, Alison. Thank you for being prepared to share your view. Like yourself, you're a nurse and a health visitor. I've got the joy of being a mental health nurse and an adult nurse, and have worked in both settings. And I guess if I was to put my experience as a community drug and alcohol nurse into the mix, I do find it quite frustrating as an academic when academic colleagues think about advanced practice as history taken, physical assessment and non-medical prescribing. And I think the skills that I utilised as a drug and alcohol nurse around assessment, intervention, psychological therapies, etc., are just as advanced as some of the skills my other colleagues would use in maybe an intensive care and a critical care setting, which I've also worked in. So that definition of level of practice for me, I think, is a really good, helpful insight around the complexities, but also the value that the variety of our profession brings to patient care and to those around us. I'm going to go to Fiona and just see, we have had some questions in, and just see where the questions are at, and then we'll come back and see where else we go with the conversation. Thank you, Fiona.
Listen, there's a question from Professor Alison Leary asking about, do you think we need a generic definition of advanced practice across all the professions? Surely each profession should define advanced practice the way the nursing has already been done by the ICN. What would be your view?
It's a tricky one, isn't it? I guess it depends on whether you're looking at it from the professional perspective or the service delivery perspective. I think from a multi-professional, interprofessional working point of view, it would be complex if there were different definitions within the team. However, the caveat is, as long as everybody was absolutely clear what each other's scope of practice was, and then was willing to work together with that, perhaps it doesn't matter so much. So the jury's out. The jury's out on that one. I'm not committing myself on that one.
Okay, and Evelyn apologise. Is there a risk that regulation is too constraining, could stifle the innovation at a time when maximising resources is essential?
I agree with that. Yeah. I do think that the regulation just needs to be as regulated as it needs to be. I don't think personally that we should be looking for really stifling regulation. As soon as we do that, it just, certainly from an education perspective, from a university perspective, it hems in your innovation and it hems in your creativity around developing, different models of innovative role development, or all those things get hemmed in a little bit. So my own personal view was that we wouldn't go too far down that full fat route, to use the analogy that Sam used.
Yeah. Brian, I've still got time for, there's a few more. Do you want me, is that okay? You're just nodding. So Beverly's asking, we do need an educational pathway for continuing care nurses. There seems to be an element that is missing completely in all of the documentation that we've done so far. That's just a comment. And I think that Cheryl's point on advanced clinical practice and pay scales is a very valid one. I mean, I don't know what your views are, that actually will there be an agreed pay scales, do you think, with advanced clinical practice, and how it all falls into place?
I guess that comes with what the decisions are made, but it sort of follows that if it's a level of practice, then it's a level of responsibility. And the pay scales tend to be based on level of responsibility. not necessarily role definition as such. So that would seem to follow, wouldn't it? That would need to be reviewed. Having said that, the way finances are at the minute, I can't imagine there's a whole lot of extra money in the system. And there probably would be some people who would need an uplift in their salary, who are already working at that level, but perhaps are only a band 6 at the minute. So, yeah.
And I think finally, the last question I've got here is from Liz saying, with ACP being from nurse, physio, paramedic, pharmacist backgrounds and registering with HE, are there thoughts on which register, or is it then a medical registration that people will end up on? Will they just stick with their own profession register, or will there be another register, do you think?
I think that just depends on where we get to in the discussion. I kind of threw in the curveball of a direct route to being an advanced clinical practitioner before, and if that, you know, that would be an independent thing, wouldn't it? But I'm guessing in the first instance that public protection comes from the role-specific registers at the moment.
Yeah, and clinical nurse specialists, where do you think they might fit? That depends on what the definitions are.
I think if it's got nurse in the title, it would be with the Nurse and Midwifery Council.
Okay, lovely. I'm going to hand back to Brian.
Thank you very much for that. And Alison, really helpful to share the Council of Deans thoughts on advanced practice and regulation and all that's involved. From an educationalist perspective, though, of course, there are some challenges in maybe some of all of those options from an educational lens. Not maybe a question, and you've heard me say this before, so it'll be no surprise, but I am very firmly of the view that doing more of the same, however we try and meet workforce demands, is just not going to cut the mustard in 2023 going forward. And we as educationalists have to think differently, have to think out of the box, and have to work more seamlessly with our practice colleagues rather than things being maybe NHS practice and higher education. Yet one of our challenges in higher education is recruitment. And we do find it hard, and we know that because we've had a survey from universities some years back now, but things haven't changed hugely around recruitment. And advanced practice and pay brings an additional challenge to universities because NHS salaries are now often higher than university salaries, which wouldn't have been the case when I came into higher education. What do you think we need to do as the voice of education in that whole debate around recruitment, retention from an education workforce spectrum?
Well, if I had the answer to that, I'd probably be leading the implementation of the workforce plan, Brian. Well, I just think we need to make sure that all of our education is accessible, that, you know, we've got enough models of delivery and different routes into the various professions that attract different groups of people, that we're very clear on what the absolute joy of being in some of these roles is. And that, yes, okay, we do need to be fairly paid as well, absolutely, but we also need some more positive stories out there about, you know, the career trajectories that people have had, the pleasure that people get on a daily basis from doing the best they can with the people that they're working with. We need a positive, sort of, a bit of positive spin, positive campaign. I think that's already started. I'm starting to see it because everybody's asking for that. But the existing workforce really needs to help the future workforce see the role as something that has its challenges, can be difficult on some days. In some areas, it's more difficult than others, but actually it's an absolute pleasure and a privilege to be in some of these professions as well. Absolute professions, you know, really credible professionals working at the height of their expertise, absolutely outstanding and delivering outstanding care.
Thank you, Alison. And I was trying to follow the chat, but things were coming in so quickly, it's quite hard to do. But one of our colleagues in the auditorium was sharing a personal example of a lack of career pathway for them in a role that they've been in, and had been hoping that a pathway would have happened. There's one thing in the profession that I love in nursing and all its guises that we don't really have very consistent approaches about is career pathways. We might have them in education. Once you go in education, the pathways are a little bit more defined. But if there's one thing that I would love to see before I hang up my hat and retire as I come towards the end of my career is a real approach to pathways that are seamless across education and practice, that allow people to work fluently and fluidly across those environments and retain and enhance good practice skills, good patient care, good educational skills, and use them continuously as the mix to educate our students, whether they be new registrants or CPD. It's an absolute desire of mine, and I know that we've had that conversation and share very similar views. Alison, thank you. On behalf of the Queen's Nursing Institute and as the chair for today, can I just say a huge thank you for you for coming along, giving of your time, the prep that you've done and the information and views that you've provided. It is warmly appreciated. Thank you very much, and an absolute virtual round of applause to you, Alison, for that. Very much appreciated.
Thanks very much, Brian. Thanks, colleagues.
Thank you. Thank you, everyone. I'm going to ask Crystal to come back on screen and on camera, if that's all right. Crystal, yeah. There you are. And in closing, I'm following my notes, but actually I'm going to go off piste a little bit, because actually what I wanted to say to you publicly in this auditorium is, as an academic, as a professor, I do get invited to speak in many different parts of the world on workforce education. But if there's one thing I always love to come to and be part of, it's this conference. And I just wanted to publicly say a huge thank you to you and your team, all of them who've helped organise today, because in my view, from all of the things that I've gone to, if there's one conference I think really stimulates great involvement, great debate, topical issues, makes a contribution, it's the QNI conference. So from one professional to another, I just want to say a huge thank you to you for your leadership and what you do with your team to get us to this place year on year from a conference perspective. It is truly warmly appreciated, so thank you.
Thank you so much, Brian, and it is a true team effort. As I've always said, the invisible team that none of you can see here today have been the creators, the developers and the producers of this. So thank you to the fantastic QNI team, and thank you for those comments. Really, really appreciated.
Thank you, Crystal. I'm sure you'll stay on the screen in case I get anything wrong in what I'm about to say next. But firstly, I just want to thank our speakers for today, to Alison Leary, to Sam Foster, to Alison Machin, and all those that were involved in the roundtable events, and to the recorded version from Alison Kitson. Huge thank you for the contribution. Now, there is a survey that we do ask attendees to complete, and in the banner, you should be able to see a link to survey. Am I right in saying that, Crystal? We would ask you to take the time and to feed that in. Crystal did say welcome Hallam Medical Group for being a gold sponsor today. But again, thank you for enabling the QNI to host this conference online. Your contribution and your commitment to this conference is hugely appreciated, I know, by Crystal, by John and the trustees and the people in this auditorium. I just, as an outsider to this and as a new fellow of the QNI, I can't thank you enough for your contribution. A huge thanks to Adina and to Aga, who have absolutely helped coordinate, organise and run this event. I had my own challenges today with IT. Adina was straight there responding to me, making sure it worked. That's fantastic. So a huge thank you to all of you. There is another day tomorrow. Crystal, I'm going to hand over to you to maybe just tell us a little bit about tomorrow. Thank you.
Thanks, Brian, and a massive thank you to you for your chairmanship today. It's been absolutely brilliant and so good that we tomorrow have another fantastic day, and we're going so tomorrow is Wednesday, and we're going to have we're starting our day. You can tell I'm just looking for my notes here, which says Tuesday and then says Tuesday again. So on Wednesday, I didn't know Brian was going to do this to me. So Wednesday, we have our chair, Professor John Unsworth, who is going to be chairing our day tomorrow. And so I'm very pleased about that. I'll be handing over to John tomorrow, and our day is focused on population health and sustainability. And we've actually had quite a lot of comments about population health and sustainability throughout yesterday. So I'm really interested to hear from the speakers that we have tomorrow. So do go check out in the lobby. You'll see the programme, you'll see the speakers, and we've also got some more roundtables tomorrow, which I know that you're going to benefit from. And we've got at the end of the day, we've got the Chief Executive for the Centre for Sustainable Healthcare, which is a new organisation to us, but it has been around for a long time. And I think that's so relevant for our delegates. And we've also, a great friend to the QNI, we have Sir Muir Gray, who's also going to be speaking from the perspective of sustainability in healthcare. He is also associated with that organisation. And I know we've had comments in the chat box about nurses leading on sustainability within healthcare provider and health and care provider organisations. So really looking forward to that. So do join us. We'll be starting at 11 o'clock tomorrow. I can't hear you, Brian.
Thank you, Crystal, and thank you, everyone. If you are a Twitter, now X, follower, do feel free to share your thoughts, share your comments, spread the news about the conference, the topics we're discussing. It's really important that we raise our voices, and that's one way of doing it through social media. The sessions are recorded. You can access them. Your colleagues can access them. If they are accessing them, please do ask them to consider making a donation to the QNI so that we can carry on the great work that leads us all to this conference today. Thank you very much for your time and your engagement this afternoon. It is hugely and warmly appreciated. Have a great rest of the day. Thank you very much.